Good
I'm just
question.
Is there a place to access those if you've already taken it?
What's that?
Is there a place to access the FEMA certificates if you've already taken it online,
Whatever
or is it
account,
just?
whatever account that you've done it before on, you should be able to access that account and that stuff.
I've had another issue with some of the tests. I've taken them, and then I go back the next day on Tavuti, and they're back.
right. I've been experiencing the same thing, which doesn't make any sense,
I have
Yeah,
to.
me too.
where they just wouldn't open at all. So some of them you'll click on them, it'll say take the test. And when you click on the test, it'll open up a blank discussion, at least for me. So I took pictures and I sent them to Tommy to let him know that I'm having a hard time with them.
Yep. No, that's exactly what I would hope that you. We are working through a couple of issues that we just noticed with Travuti.
Okay.
I didn't think your class had issues, but we had a couple other issues with other classes. We found some solutions, but we're taking care of them now. So if you do run into that, you have a problem with a test or you have some issue, then definitely just like do exactly what you did. That was fantastic. So if you run into a problem, take a picture, make sure you send that to Tommy and that communicate with him, and we'll figure that out, because that's what we need to know, because he and I can see certain things as we build it, and we go through the process, and a lot of times it looks great to us and it works and it doesn't have any issue, and then when you go to do it, it's a little bit different. So definitely let us know. We have changed some things with the new edition and gone through some stuff. So definitely let us know if you're having any issues, and we'll make sure that we address that and we don't penalize you for that as well. So make sure that you just communicate, and that's going to be the biggest factor, is just let us know if you're having issues or problems. Take a picture of it, send it to Tommy, let him know what's going on. That's going to be really important. Okay.
When I emailed him last night, he told me this morning, because I was having a problem mainly with the videos. I definitely retook a bunch of tests that I know I took. One of them being I took one in class yesterday right after we all got out, and it was the same test I had taken 3 times already. And I had emailed him and let him know that it was having me retake tests, and on top of that, the videos in some of the slides, they weren't like, I would watch them like 3 full times and they wouldn't mark it as correct or it was done.
It
So
wasn't marked as complete.
yeah, it was marked as incomplete, but it said required video.
Mine are
Okay.
doing the same thing as well.
Okay. And that's interesting. Okay, that's a setting or something. So just if you could communicate that, that would be helpful. There's a button that when you put up stuff, sometimes you got to tweak it. Just let us know where if you run into that problem, let us know. The biggest thing, making sure you go through the quizzes and that stuff when you have them. But yeah, we can figure that out.
Okay.
Just let us know if you're running into problems, and because to be honest, if you're running into problems, probably somebody else is, because that's a setting that we need to fix. So let us know as soon as you do, and we'll try to get that taken care of. And I'll talk with Tommy when we're done here. He's running around with classes this morning, so we had an instructor bang out, so he's running around doing a couple of things. So you may not see some changes immediately. It may be later on today or this week, later on tonight, when I get a chance to sit down and do that. But make sure you communicate with him. Great
Okay,
feedback.
thank you.
Anything else? All right. So today, what are we
Did you
talking
already
about?
go over the plan for, oh,
That's okay. What's up? Did I already go over the plan for what?
I just wanted to know if you already went over the plan for this afternoon.
So again, this afternoon, the plan is that you're going through mandatory reporter training and the FEMA training at home, not here. Nobody is coming here this afternoon. You're required to finish those trainings and send us their certificates of that completed training. Tommy has sent out an email this morning, you should already have in your inbox, with in
I got
regards
it.
to that. Okay.
Okay, thank you.
All right. So yes, so you don't need to drive in after we break here and I get through the stuff. You don't need to drive in here for class today. All right. Any other questions? All right. Fantastic. So today, what we're going to talk about, airway management and pharmacology, right? So some really important pieces, right? Number one, if we're going to be giving somebody drugs, we're going to be giving somebody medicine. That's really important. And sometimes you're like, well, this is over, we're giving aspirin. It's just over-the-counter medication. It's still really important because you give it to the wrong person and you could really complicate issues and problems. So you need to know what you're doing and why you're doing it and how to do it appropriately. Really important. The other thing we're going to talk about today too is airway management. Airway management is one of the key things for you as an EMT as a skill. And it's really how, people are going to judge, are you a proficient EMT? Are you not proficient? And what's going on? Airway management is one of the most important things. It's all important for sure, but airway management is one of the key things, right? And why would it be one of the key things that for us, for you as an EMT, to know? Why is it important? John, what do you think?
You said John?
I said John. John P.
What was the question again, Dennis?
Airway management, why is it important for you as an EMT?
It's a crucial vital sign. There's no airway, then dealing with a real big problem.
Yeah, they're going to be dead, right?
Yeah.
So, yeah, you're absolutely right. So airway management is really important. It is one of the most important things we do. And BLS comes before ALS, right? If I can manage an airway BLS and I can do that appropriately, I may do that. At some point, sure, I may put in an intubation tube, I may do other things like that, but initially, and first and foremost, I'm going to take and manage the airway BLS. And it is one of the critical skills for you to be able to do. So it's really something to kind of think about. So thank you, John. And that's how, and just so you guys know, from time to time, I will ask a question and I will call on you. So please be prepared for that. This is part of the class. I do like to take and go around and talk with people and ask questions as we go through, because to be honest with you, it's super important material, and I am going to take and ask some questions from here on out randomly with individuals as well. So just throwing that out there. And if you don't know, that's okay. I'm fine with that. But I do want to increase some participation and have some discussions. So just fair warning, I may do it a little bit differently than some other folks. My mom has always told me I'm special, but it's important for us to kind of go through. So airway management, that's where we're going to start. And I'll get off my little soapbox and we'll start going through, right? So one of the big things, how are we going to manage that airway? What do you see here? What are they doing? What do you think, Rose?
Oh,
You there, Rose?
Yeah.
Okay. So what are they doing here? Do you see the picture, or did I
They're
not click on
getting an
it?
airway for the patient.
Yeah, they're providing they have the airway. The guy's squeezing the bag. So you're not sure. I can't tell if there's an oral airway in there. It looks like he's clenched down, right? You can actually see his veins popping up there. So it looks like he's almost seizing, and he's probably trying to do positive pressure ventilation. And this may be somebody who's agonal respirations. It may be somebody. Now, this isn't the best mechanics. Obviously, they're trying to load him and put him into the ambulance. So that's a challenging piece. Sorry. So that's a challenging piece as you kind of go through the process. But really making sure that you're maintaining, getting that airway, securing that airway the best you can, right? Now, you could use, with this airway, we may do different things. We may put an oral pharyngeal airway, nasal pharyngeal airway. You guys kind of touched and did that a little bit the other day. But trying to positively ventilate a patient can be difficult as well. So just for some food for thought as we kind of go through. We'll try to watch a couple of videos. Sometimes the videos, depending on how well your bandwidth is, but we'll kind of see what we can do with that, right? All right, so airway, where's my thing? There we go. Respiration. And when I say respiration, what the heck am I talking about? What am I talking about when I say respiration?
The exchange between gases.
Yeah, okay. So kind of an exchange between gases, not bad answer, right? So really it's commonly referred to as ventilation or breathing. Sometimes they are used simultaneously, sometimes a little bit different. There are true physiological differences between ventilation and breathing, and various types of respiration. Okay, respiration really can be broken down into 4 distinct components, right? And those components that we're really talking about is pulmonary ventilation, external ventilation, internal respiration, and cellular respiration. And we'll talk about those a little bit more, so don't freak out about that. But those are some of the things, as we're going through this discussion, some of the things to kind of think about, okay? Physiologically, the term respiration really refers to, like you said, that gas exchange process that happens between the alveoli, those little sacs, right, or the cells of the capillaries, and that utilization of glucose and oxygen during normal metabolism within the cells, okay? Really things to kind of think about. When we look at external respiration and internal respiration, right? Some things to kind of think about. Air goes, the biggest thing that you want to think about, right? Air goes in and out, blood goes round and round, right? Kind of important for this whole living thing, right? So pulmonary ventilation, right? Or simple ventilation or breathing is really a mechanical, it's the mechanical process of getting air in and out of the lungs. Okay, it is a mechanical process. With that, sometimes minute ventilation and alveolar ventilation can be thrown out there too. But when we think about, as we breathe air in, what are we breathing in? We know it's not 100% oxygen, right? We know that the air that we breathe in and out has nitrogen and carbon dioxide, as you can see there, and oxygen as well, right? And when we expire, you think about it, you use just a little bit of oxygen, you get some nitrogen going back out, and you get the carbon dioxide. You get more carbon dioxide going out, right? So we bring air in, we take some oxygen, we offload some carbon dioxide, and that's what we do over and over and over again. That gas exchange is really an important piece, if you think about it, right? That is what keeps us upright and moving forward. So external respiration is really the gas exchange, that it's the process that occurs between the alveoli and the surrounding capillaries. And this external respiration is also referred to as alveolar or capillary gas exchange. Really, what it does is it oxygenates the blood. It helps to eliminate the carbon dioxide, You got to push some of that stuff out. What happens if you get too much carbon dioxide within your system?
Don't you consider that like anabolic shock?
You can have
You
some
become
anabolic.
too.
Your body becomes acidic.
Okay. Yep. And Caroline, did you have something?
Oh, I was the one who originally said your body becomes acidic.
Mm-hmm. And what happens? What happens with that acidity? Like, how does the body buffer that?
Oh,
It needs oxygen.
Oxygen.
Feel the oxygen, that gas exchange, right? Pushing some of that off. Sometimes what happens is that we see an increased lactic acid buildup because that's how the body's trying to buffer some of that carbon dioxide and some of those types of things. So there's a whole really interesting process as it kind of goes through. When another term to kind of think about too is internal respiration, right? That internal respiration is a gas exchange process that occurs between the cells and the systematic capillaries. That internal respiration is also known as that cell or capillary exchange. And really what we're talking about here is, or are the cells delivering oxygen and removing that carbon dioxide? That's the process. That's where the rubber meets the road, so to speak, right? That's where we have the body uptake oxygen, and that's where it offloads that carbon dioxide. And that process is really that internal respiration is where that process takes place. Now, cellular respiration, and sorry, I haven't had enough coffee yet, but we'll get there before the end of the day, right? And so that cellular respiration and that metabolism, also known as anabolic metabolism, really occurs in the cell. It breaks down glucose with the presence of oxygen, also produces high amounts of energy known as ATP, and carbon dioxide in water typically is a byproduct. So within the cells themselves, right, we have this process of breaking down and requiring to create energy itself. It requires oxygen to do that. Okay. Can be very convoluted, very complicated, trying to just keep it simple, right? As we kind of look at it, you can go in depth. You can study this for semesters upon semesters within school and collegiate level and that type of stuff. There's people that this is their whole function. As an EMT, we need to know a bit about it so we can understand what we're doing and how we're doing it and why we're doing it. But we also need to know, how do we correct it? How do we put our hands on a person, and when should we force air it? When should we take and do other things? You know, do we give them oxygen? Don't we give them oxygen? What's going on in this process? And if we do give them oxygen, what is that going to look like? We know that over the past however many years, right? When I first started, we used to take and give everybody high flow O2, and the National Registry still, yeah, we do more high flow O2 than what you're going to see in the field, right? In the field, realistically, right now, is do they need to have oxygen? Great, we'll give them oxygen, but we are monitoring that. We're doing a pulse oximetry. We're looking at that because we know that oxygen now, more than we ever have, is not a benign medication, and that's what oxygen is, a medication that we're given. So it's not benign. We can increase the free radicals so much that it actually can be detrimental to some of our patients. So just slamming them with high amounts of oxygen is not something that we're currently doing within our practices. It's something you're going to do a lot with National Registry. Don't let me screw you up with that stuff, but think about when we go through and start thinking about, what are we doing? What's within our protocol? How should we be doing that? And how are we administering that? We're not even giving high flow O2 to every single cardiac patient. Somebody who's having a heart attack, that their heart is not getting enough oxygen. Sometimes we're just giving them a few liters of oxygen, right? Because that's all that they need. That's not the problem. The problem is that the heart's not getting the oxygen, but it's not that they don't have it within their system. It's just a certain part of their system is not getting it. So it is something to kind of think about as we kind of progress and move forward, right? So let's talk a little bit about the system itself, right? And talk about the respiratory system with the upper airway. When I say upper airway, what am I talking about? Give me an example of something that's within the upper airway. You got tons of structures there. What's What's one structure that you can think of? What do you think, Michelle?
For the upper airway, like a
Yeah,
structure.
give me something in the upper airway.
I think the trachea might be in the upper airway, but I'm not 100% sure on that one.
Yeah, that's pretty close to getting lower airway, right? But you know, I'll
The
give you
throat,
that. It's within
esophagus.
there somewhere. What do you think, Jessica? Do I have to click on you here? Oh, hold on. I think I clicked on you one. There we go. Oh, try that now. There we go. We got you. Go ahead.
Can you hear me now?
I can hear you now.
Your nose, your sinuses.
Yeah. Your nasal, your nose, your nasal cavity, your sinuses, all that type of
Pharynx.
stuff. Somebody else had something. Adam, was it?
The pharynx.
Pharynx? Good. So start thinking about some of those things, right? And start thinking about what happens within that upper airway. So some of the things that happens is that upper airway, what the heck do we have an upper airway for if you think about it? And what we do have is we have that upper airway warms and humidifies air, filters it, right? As you go through all the nasal hairs and nares and all the different pathways, helps to filter the air that we breathe, right? It also helps to humidify and warm the air before it enters the lower airway. Our lower airway is a little bit more sensitive. Think about it. When you go outside and it's -12 outside and it's super cold, not that you guys actually get that down here in Massachusetts. I am from Maine, so it gets a little bit colder from time to time. But you think about that when it's super cold outside, what happens? You know, you start breathing through your mouth. What happens? It forces you to cough because your lower airway structures are a little bit more sensitive, right? So start thinking about that, right? And also then we have the tongue, this huge, big old fat muscle in the middle of our airway that helps to move things along. But somebody with decreased responsiveness, that can be a huge problem, right? So really, you know, think about some of these things as we kind of go through. So let's take a quick look at that. And there you go, right? So we have the nasal cavity and we have the up top, the nasal pharynx, right? That nasal pharynx is important. You know, that's one piece. Then we have the oral pharynx. When we have everything that comes together, that is the pharynx, the laryngeal pharynx. So we can break it down into three. The pharynx can be broken down into three sections. You have your nasal, your oral, and the laryngopharynx, right? I can't speak today, but that's okay. So as we kind of look at what's within each one, I've got a little feedback here. Jessica, I'm just going to mute you, but if you need to, just raise your hand. You got a little feedback going on there. So, and it could just be me. So the oral pharynx and the nasal pharynx, we actually insert devices to help kind of augment those or keep those open as we go through. So things to kind of think about. Air entering through the mouth and the nostrils travels into the pharynx. That air entering the nasal passages goes through the nasal pharynx and it travels down into the oral pharynx. And the two passageways are later into or can it go into either the trachea or the esophagus. That's, you've got two paths you can go. You can either go into the stomach or you can go into the lungs. And that's why, you know, we really focus a lot of times on that trachea. It's really important. If somebody's had a stroke and they can't maintain their own airway, if somebody's completely unresponsive and you're doing CPR on them and you're huffing, puffing, and pumping, if you're doing that process, they aren't necessarily maintaining their own airway, and you're gonna have some air go into the stomach, and you're actually gonna see that go down through, and you may see their stomach. No matter how good a CPR you have, if you don't have a definitive airway, you're gonna have some air going into that stomach as well, right? So the trachea, that passageway, is really the passageway where it goes into the lungs. You know, food and water and all that stuff should be going into the esophagus. When it doesn't, then we can have aspiration pneumonia. We can have other really significant issues and problems. And the big thing, right, the big thing when we think about it, what is the structure that you can see here, right? What is the structure that really determines, is it going to go into the stomach or is it going to go into the lungs? What's the name of that structure? Which one of these lines here are we really talking about that is kind of important?
The epiglottis.
Epiglottis, that's the money, right? That's a leaf-shaped flap of cartilaginous tissue, right? And that helps protect, that truly helps protect the trachea and that airway. So when you're swallowing, when you're taking in food, when you're doing that, that flops down, protects the airway, and allows the food or the water or whatever you're consuming, maybe a few adult beverages, who knows, but that allows you to get that into your stomach versus into your lungs. And that's critically important. Sometimes, like I said earlier, sometimes because they're unresponsive, because they have some type of injury, because they've had a stroke or something happens, that epiglottis is not working appropriately. That's a huge problem, right? And that's a really, really important structure to really help maintain that airway, right? And yeah, so there's a whole lot of other structures as you kind of think about and just start getting familiar with this, right? And everybody's a little bit different. Sometimes somebody has a big mouth. I know I'm so funny, but you know, sometimes their oral structures are very large. Sometimes they're not. Sometimes you need to figure out how you're going to do that when you're looking to place a nasal airway. Have they had multiple fractures? Have they had other things happening? So upper airway, knowing the structures and what you're coming up against, really important. I know Tommy, I think it was your class, Tommy decided to demonstrate the application of a nasopharyngeal airway, right? The other day. Well, if somebody's had some major cartilage issues or damage or broken their nose a bunch of times, it may not work. So knowing that, okay, I'm not doing it wrong, but there's just some blockage, well, we'll try the other nostril, we'll see what's happening there. So it's just important to kind of understand some of the anatomy as you move forward and understand some of those pieces because that's important, right? Now, yes.
So let's say that someone has had, I can't even remember the specific term, but someone has gotten a tube stuck in through their throat, like trachea area. Can you?
Yeah, so somebody's been intubated?
Yes, intubated, sorry. But if someone's been intubated, are we still able to use the OPA and the NPA, or is there other ways to do it? Because obviously it causes a scar and scar tissue.
Sure. So if they have a tube sticking out of their throat, the other things aren't going to be beneficial. If you're talking about that they've had it previously, right, that they've been intubated before, you can still use those oral airways, those oral adjuncts. I'm still going to take and go out, right? So I can shove that tube in their throat. But before I even get there, because number one, I got to set up my stuff. Number two, I got to make sure that it is the right direction that I'm going to go. So are they maintaining their airway? If they're not maintaining their airway, I'm going to take their airway. I'm first going to take the airway with exactly what you're going to do. I'm going to take and open up their airway. I'm going to use a jaw thrust if I think that there's any cervical issues or problems. If not, then I'm going to do a head tilt chin lift. And on a real live person, it's a bit different. You truly got to do a good head tilt chin lift. It seems like you're going to pop off their head, but you're really not going to. But you want to take and open up that airway. And then I'm going to use the airway adjunct. So I'm going to take an oral airway. I'm going to put it in an oral airway. If there's no gag reflex or anything like that, if they start gagging, take it out. I know that I can still do a nasal airway. So even though that they've been intubated before, even though they may have some scar tissue, I'm still going to do the BLS maneuvers. I'm still going to do that. And then I'm going to decide. It's a lot of times when I'm thinking about airway and airway obstruction and different things, if I go out to an asthma patient, one of the questions I always ask an asthma patient, have you been hospitalized? Yes or no? And if you have been hospitalized, have you ever been intubated? I know that an asthma patient, if they're that bad of an asthma patient and they go into status asthmaticus, they get really sick really fast and they typically buy a tube, it's very likely that they're going to get another tube as well. So it's important to kind of listen to the history and listen to your patient. Your patient's going to tell you tons of stuff, right? And sometimes the best EMTs that are the ones that can actually listen and decipher what they're actually trying to tell. They'll tell you everything they want. They're stressed. They're trying to figure out how to communicate that. Some are better than others. Some know the system. Some are playing the system. Absolutely, fully understood. But at the end of the day, we're there to pick them up, treat them professionally, make sure that we get them to the appropriate facility, right? So some things to think about with that law, and Alyssa, right? So did that kind of answer your question that we're still going to do the BLS maneuvers? Obviously, if I got a tube sticking out, then I'm just going to put the bag and squeeze the bag. But if I don't have that, then regardless if there's an airway, I'm going to manage that. And if I'm fully managing that, I may start with tilting the head, opening the airway, giving some breaths. If that works, great. If they're still not maintaining their airway and I'm still doing that, I am, as soon as I can, going to put in an oral airway if there's no gag reflex. If there is a gag reflex, or even if they're sitting there talking together, breathing so hard, and I think I'm going to have to manage that, maybe I'll try to place in a nasal pharyngeal airway. A lot of times people have that barrier of, oh, I don't really want to shove that up their nose if they're not breathing well and they're still talking to me. Well, maybe that's what they need. They need some help with that, right? Maybe they need to provide their own positive pressure. You know, what we have and what you have as an EMT that I didn't have when I was starting out is CPAP. And CPAP is an amazing thing. It's decreasing the amount of intubations that we do tenfold, right? Now, pretty much we intubate dead people or people who are in cardiac arrest or significantly. Before, we would watch people who are having some major issues and problems, and they get to a point, we tried positive pressure. That's super hard to do, but CPAP has made a huge difference. And you can do that at the BLS level, and we'll talk about that more throughout the class. So, but anyway, so I digress. Hopefully that answers. If not, chime back in and let me know, and I'm happy to kind of do that as well. So the lower airway, what are we talking about? We're talking about the trachea. This is where the passageway for the air to go into the lungs, right? It extends from the larynx to the carina, and that's a nice little lovely test question / national registry question. Sometimes you may see that somewhere somehow. But that carina is kind of an important piece. That's where things kind of break off and go other places. It's where the trachea splits off to the right and left main stem. The anterior portion of the trachea is really, or the front part of the trachea, right? Anterior, front. That front part is really strong C-shaped type of cartilage or cartilaginous. There we go. I spit that out. These rings that really help to support that structure. It's more of a rigid structure versus the esophagus, which is just pliable, whatever, right? So this has some structure. You can, reach up in your own neck and you can feel right up in here, you can feel that cartilage. You can feel your neck and feel that piece. Go ahead and try that. I know you're all doing it, right? Of course, I spasm a little bit there, but you can actually feel some of that cartilage right in through there. That's what it is, right? It's more rigid type of structure. Posterior wall of the trachea is really more muscle, and it's not as rigid, right? But it's where some of the muscles kind of take place. As it goes down, you're going to have the right and the left main stems, right? That right and left main stem bronchi, and they are two of the major branches of the trachea that extend down below. Then they get to smaller ones called bronchioles, and then and those bronchioles become increasingly smaller and smaller and smaller, and actually go into some very smooth muscle, and to really, that's where it goes down into where you can have that gas exchange into that lower airway and kind of all branches out. But they get just smaller and smaller as they kind of go through. Where we have one thing to think about, right, is this is where you want to think about the things like asthma, right? And asthma is one of these things. And when I think about lungs and I think about treating my patients, I really break it down into two categories when it comes to respiratory. And I think about, are they tight or are they wet? Is it a constrictive problem that they don't have the space, that they have mucus, that they have that constriction, so they're tight? Or is it that they're wet, that they're building up fluid and they're actually drowning in their own fluid? So are they tight or are they wet? And for me as a paramedic and you as an EMT, that determines what direction you're going to go, right? Are you going to give albuterol, which you can do as an EMT in the state, right? Are you going to go down that path, or are you going to go down the nitrates path? Or you're not going to be able to give the nitrates unless they're prescribed to them and for different reasons, but are you going to go down a different path that you're thinking, okay, well, it could be cardiac, it could be something else, it could be fluid in there. We got to keep them maintained and setting up. I got to call for a paramedic that can give nitrates and do that stuff. I got to think about, am I going to give CPAP, right? CPAP works with both, works extremely well with wet, and works really well sometimes with tight. So am I going to give CPAP? And for me, if you're already doing CPAP, well, then how else can I augment that treatment? You know, I may give nitrates, right? I may want to offload if they're wet. If they're tight, then I continue with the albuterol and different things. So again, kind of thinking about what's going on. Are they tight or are they wet? And when I mention tight, this is where it happens. This is where that magic happens, or unmagic happens. That's where you get that restrictive. So you get tight around the bronchioles, the smaller airways. You get tight and constricted, so they can't offload that air that's within their lungs. They gotta push it out, and they can't continue to do that as much. So just food for thought as we kind of go through. Think about the cartilage. Think about that C-shaped piece here, right? Oh yeah, I forgot I can draw. I love this. So you can see this C-shaped here, right? See, isn't that great? I can really draw so well, mouse. But that C shape and then that smooth muscle behind. But this mucus cartilage, this area here can become more and more restrictive, whether or not it's some type of pneumonia, get fluid buildup, or it's chronic bronchitis, or if it's asthma, you get that restriction within this airway, and that restriction can create havoc as you kind of go through. So things to kind of think about as this happens. All right. Sorry, I'm getting a little behind here, but then we want to think about as the gets smaller, trachea gets smaller and smaller, goes into bronchioles, does all those things. Where does it go? It goes into the lungs, right? And our part of the lower airway here, part of what we're talking about are the lungs themselves, right? The bronchioles terminate into thousands of tiny air sacs into the lungs. These are called alveoli. This is where the work happens. These are the worker bees. These are the site where the gas exchange between the alveoli and the blood capillaries happens. These are the ones, this is where, like I said, the rubber meets the road. That's where that gas exchange happens. When you're looking at the lungs, what do you see here? Do you see any difference between the right side and the left side?
Yeah, one has
Lobes.
The right side has 3 sections and the left has 2.
Right. So you actually have a different number of lobes between the two lungs. And why would that be? Any idea besides we just want to keep things complicated?
The heart.
Yeah, you got a few more structures in there that you got to think about, right? You got the heart, right? You got that piece with that. So that's something to think about. Jessica, I see you raised your hand because I muted you. Sorry. Let me unmute you, and then if you mute
No,
on your
I was just gonna say that the heart is there. That's why there's one side bigger than the other.
yeah, absolutely. If you mute on your end, then
Yeah,
the next
okay,
time you should be
I
able to
can keep
unmute.
it muted on my end. That's cool.
What's that?
I said I can keep it muted on my end. That's cool.
All right. So if you do that, then if I mute you, it's harder. I think I muted John. So John, if you raise your hand, I'll unmute you. But if I get distracted and talking or whatever, you can't unmute. So that if you guys just mute yourselves afterwards, then that's fantastic. All right. So the lungs themselves, as we kind of think about that, yeah, there's different lobes on each side, right? So the alveoli we talked about. The other thing to remember that the lungs are surrounded by a couple layers of connective tissue, right? The pleura, right? The visceral pleura is the innermost covering. So you get like a sac, that visceral pleura. You can see, this is where my artistic skills come in, right? This visceral pleura, so good. There, that goes all the way around. And that's the first sac that uncovers everything, right? And that's the innermost layer. The parietal pleura, right, is a thicker, more elastic layer that adheres between. And between the two, there's a small space that is negative pressure, right? The other thing to kind of think about too is what other thing in this picture is absolutely critical for breathing?
Diaphragm.
The heart.
Absolutely. The heart, in essence, that keeps things going, sure, but the diaphragm, right? The diaphragm is the muscle that separates the two, right? But it's also the major muscle used in breathing. It's responsible for 60 to 70% of that 60 to 70% of the effort of ventilation is really done by the diaphragm. And so it's really kind of important when you think about this into the process, and we don't think about that as much, but it is an important muscle that helps. Not only does it separate the upper, the lungs and all of the below, but also it's really important when we think about breathing itself. It's really important for ventilation. It's really important as we breathe air in and out, right? And we create that negative space as we go through. Inhalation. Let's talk about inhalation. Air going in and out, right? And I say this all the time, right? Air is going in and out, blood's going round and round, life is good. And really it is that simple, but it's much more complicated. But air needs to, first of all, go in and out. And how does that happen? As we breathe, right? It is an active process, so to speak, is that to get air inside the lungs. How would you describe that? Inhalation to get, let me clear off my little drawings there, right? So how, without, maybe you read the textbook, maybe you got a completely underway, but how would you describe airflow or inhalation in your own terms? Like, how would you describe that for you right now? Anyone want to volunteer?
Breathing.
Or I will select a tribute. Oh, somebody talked.
Breathing through your nose and mouth.
Okay, let's talk about that a little bit more, right? You're breathing through your nose and mouth. Who was that? Was that?
That was Jessica.
It was me. The movement of air, I said.
Okay, but how does that happen? What makes that happen?
The diaphragm.
Yes.
It's an involuntary muscle. And so you could, like, if you want to take a deep breath, you could, but but it's also gonna do it involuntarily when you need the air.
And what is it doing though?
When the diaphragm constricts or expands, it causes the negative air pressure into the lungs, so it's kind of like vacuuming up air.
Right.
Or pulling it in.
Right. It's creating a bigger space, right? So it's causing that negative space. So then, because it's getting larger, it's going to allow that airflow to come in. So the diaphragm moves slightly downward, which flares the portion of that rib cage. So if you look at it, right, and you look at the area right here, right, that diaphragm goes down, makes a bigger hole that needs to be filled, right? Not only does that happen, but also the intercostal muscles, the muscles between the ribs, all through here, between every single rib, we have our intercostal muscles, right? And they're actively doing stuff all the time. And the intercostal muscles pull the ribs and the sternum upward and outward. So again, it's creating a larger space, which then is going to allow the airflow to go in. So this creates that negative pressure inside the chest cavity, which draws the air in through the nose the mouth, the trachea, the bronchi. All of that happens because of this negative pressure that builds up. So it's an active process to do that. Does that make sense? So that volume, that volume changes. Now we can take a deep breath. You're right? I can forcibly take a deep breath in, and I can force myself to do that. But as we kind of go in and draw that air in, right, we create negative space to do that. Now, if I try not to do it, at some point I'll be forced to do it, right? Because it is not only an active process, but it also is an inherent process that's going to happen no matter what. Caroline, did you have something?
Well, the more I look at the intercostal and diaphragm, the more counterintuitive it seems, because when I hear contract, I think that it's bunching up. But is that just something that we just have to put together as we learn about airflow? Is that when we say diaphragm and intercostal contract, it actually would just be expanding?
Well, so right. So it's hard when you first think about it, right? So yeah, it's something that we need to start changing what we're thinking about. Muscles do one thing, right? They contract or they relax. They don't do much else. So if you think about how the diaphragm is normally here, right? It's this nice little shape here, and then that's its relaxed state. So when it contracts, it just contracts down. So it's tightening up. It's just tightening up in a different motion than when you think about it, right? It's still contracting, it's still tightening, but because it's contracting, it's making a larger space. Same thing with the intercostal muscles, is that they're contracting, they're still shrinking, but because they're shrinking, it's forcing with the physics and the anatomy of the chest, it's forcing it to create a larger space. So it is an active process, and it is something that we talk about a little bit because it's important. Breathing is kind of important. So in knowing what you're trying to do is important as well, but we need to recognize that inhalation itself is an active process, and the muscles are contracting. That's what they're doing. They're getting smaller, but by them getting smaller, it's causing the cavity to increase in size, and that's how the airflow actually gets in. Great question, and it is something that you need to start thinking about just a little bit differently. If you know, and the biggest thing, anatomy, physiology, learning where things are, is going to help you in the long run. Not only is it going to help you with trying to communicate effectively with other healthcare professionals, but also it's going to help you to understand kind of what's going on. If you know general anatomy, physiology, and what's happening, you can have a great idea of what's going on with this body, what's going on with this patient that I need to take care of. Great discussion there.
What you did with your hands made sense for the diaphragm as you overlapped your hands on top of each other for the contraction. That made sense.
Okay, great. So me talking with my hands is not a bad thing sometimes. My kids laugh. My wife and I talk. My wife is a second grade teacher, and I teach from time to time through video, so I use hand gestures. So our kids completely laugh at the old people. But that's how we want to think about inhalation itself is an active process. And when somebody's sick and they're trying to really breathe in, and sometimes because they're sick, or think about an asthma patient, right? They can inhale, they can breathe in, but their problem is they can't exhale. They can't get it out because of they can get it in, but now they got to overpower the constriction to get the air out. So you'll see them peep. They'll put their lips together and they'll kind of purse to get it out. We'll talk about that a little bit more later if I don't get too distracted. But now let's talk a little bit about exhalation, right? And this is where the respiratory muscles should, right? And theoretically, they're going to relax, and the chest cavity itself becomes smaller, putting the air inside under greater pressure. That air flows from higher pressure of the chest cavity to lower pressure of the atmosphere. So, and again, that's like anything, right? We're going to go to an area of high concentration to lower concentration. high pressure to low pressure. It wants to equalize. It wants to get back to normal. So these are some things to kind of think about. And this process here is that the muscles relax. So as during exhalation, as the diaphragm, the intercostal muscles relax, this moves the diaphragm upward. It moves the ribs and sternum inward and back to normal resting position, which then pushes out the air. So you contract everything, make the chest larger, air comes in, relax everything, makes it smaller, air comes out. So that it's the muscles relax, the ribs will relax, all that type of stuff, and that forces the volume of the air out. Because this involves relaxation and that type of stuff, typically exhalation is less energy is required for that. More energy is required for inhalation because you're actually using that. It's really considered, exhalation itself is really considered to be passive. Now, sometimes some respiratory diseases affecting the lower airway, which would be what? Something affecting the lower airway. When I talk about airway diseases, what's something that pops in your head? Anything?
Is it pneumonia?
Pneumonia is more of a infection, right? But what about a long-term disease that they're going to live with forever?
Chronic lung disease.
Chronic lung disease, COPD, or what's another one that we think of? We hear a lot of.
I might not be right, but I'm actually really just asking more of a question. But like, so I know some people only have like one, either a smaller lung. I don't know the term for it, but a smaller lung or only one lung.
Okay.
So would that impact it?
That would
Like,
impact some. Yep.
okay.
What's one that we hear a lot about? And you'll see patients with it too, quite a bit, flare up, especially sometimes it can be affected by pollution or where they live or other types of things. But it's also a disease that when we think about respiratory, we think about this and the medications that you can give because of this as well.
Asthma?
Asthma, right? Asthma is one of those things. Jess, did you have a question or were you going to answer that?
I wanted to answer asthma and chronic lung disease.
Yeah, chronic lung disease, asthma, very good, right? So some respiratory affects the lower. Asthma is a great example of that, right? COPD affects the lower. And that's where, again, the issue is that there's increased resistance so that you can get air in, or sometimes you can't get it in, but really they can get air in and they can't get the air out. So they have to take and create some type of way to kind of overcome that, and that you'll notice they appear slips, their tripod position, they're doing whatever they can to really maintain and to breathe, and you'll see that, right? We'll show a couple videos in a little while that show some respiratory distress, that show some patients who are struggling to breathe, and that you can see those types of things. So just keep that in the back of your mind, but they actually have to force that air out. When they force that air out, it creates more energy expenditure, more challenges and more requirement of gas exchange. So they're working harder and harder and harder to breathe. That's not necessarily a good thing if they have some other conditions and some other problems going on. So again, it's something to kind of think about as we continue to progress and go through the process. Mechanics of ventilation, right? The control, where does this happen? Where does that magic happen, right? We know that that there's parts of the brain stem, chemical, chemoreceptors themselves, right? So breathing happens. It's an automatic process. Now we can mess with it, right? We can take deep breaths. We can force ourselves to breathe faster or slower and that type of stuff. But it is an inherent thing that we also have stimulation from some of the brain centers itself. So really the respirations are controlled by the nervous system, right? A variety in different ways. You'll have different dorsal groups and ventral groups, and you can get a whole lot in there, right? And sometimes it's not just the nervous system itself, but also some of the chemoreceptors. So continuously monitoring levels. So up in the brain, it's continuing monitoring levels of what? What does our respiratory center, what does our, in a normal, physiological, normal person, what does a body gauge, or how does the body gauge respirations? What does it look at?
Oxygen, carbon dioxide, and then the acidity, how acidic it is, so like the pH.
Right, right. Good, very good. So all three chemoreceptors, right? Oxygen, carbon dioxide, and pH, or hydrogen levels, in that arterial blood really help to stimulate increase and decrease impulses of respiratory rhythms and the control centers and that yada, 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 right? You can get pretty complicated with that stuff. Typically, right, the respiratory system primarily responds to carbon dioxide levels in a normal, physiological, normal adult, right? The chemoreceptors really key in on that carbon dioxide level. That carbon dioxide level increases, then your respirations will change to try to mitigate that. We want to be in our happy place, right? We want to be in homeostasis. Our body wants to normalize levels the best it can, and it will change other things to do that. So it's going to increase respirations, it's going to decrease respirations, it's going to do whatever it can do with however it's programmed to do that. So that's kind of important as you think about that in a normal physiological person. Now, I keep saying normal physiological person because one of the diseases that we deal with actually changes that, right? Our COPD patients, right? They actually, their drive changes and their body system changes with some of these diseases, that they're actually on a hypoxic drive versus, or really on oxygen versus carbon dioxide because of where they're at. So it depends kind of what's going on. We'll talk about that a lot more later, but just realize that the nervous system control, respirations, it's done really on carbon dioxide as a primary, but it can be oxygen, carbon dioxide, and even pH levels or hydrogen levels. Hypoxia. What is hypoxia? When I say the word hypoxia, what does it mean to you? Charles, what do you think?
Go with low on oxygen.
Okay, absolutely. Low on oxygen. How the book would say, right? Or the textbook, right? Hypoxia occurs with inadequate amount of oxygen. So, i.e., not enough oxygen, right? So, not enough oxygen is being delivered to the cells. Hypoxia is not good. It's bad. Now, what happens with hypoxia? So what happens when the cells aren't getting enough oxygen to be delivered?
There's more carbon dioxide.
Okay, but what can you see as an EMT? You walk into the house, somebody's hypoxic. How in that world do I know that they're hypoxic? What is that thing in my head that's
They're hyperventilating.
Their color.
Their color. What's that called?
They're confused.
Cyanosis.
Cyanosis. They look blue, right? They look like they're not good, right? They look like a little Smurf, right? Not that.
What about confusion? Confusion?
Yeah, so a lot of things come with hypoxia, absolutely, and we'll talk about that. So confusion, altered mental status, huge in so many different medical issues and problems. You're absolutely right.
The signs of hypoxia sometimes mimic those of choking, because I know when you're choking, if you're choking for so long, you can turn blue.
Yeah.
So
yeah.
It mimics the signs of choking. So can there be like mistakes like that on the field? Or like is hypoxia, there's way more to hypoxia than just the blue? Because I mean, of course, blue is the most natural like sign of hypoxia. You can notice it right away, but choking, can that sometimes be taken as choking?
Choking causes hypoxia, right?
Okay.
So what causes that hypoxia? Could it be different? You know, it could be choking, or they could be hypoxic because they're asthmatic, right? And they're trapping air and they can't get that oxygen exchange. So it could be because of asthma. It could be because of choking. It could be because of trauma. It could be whole host of things. So hypoxic is more so just a term that we use to say that somebody's not getting enough oxygen. Now, it could be anything, could be medical, trauma, physiological, could be some other reason, right? One of the things to see, are they hypoxic? Cyanosis or turning blue typically is a sign of severe hypoxia. Somebody doesn't usually turn blue unless they have a complete oxygen issue, for the most part, right? Somebody who's super cold, lips will turn blue, that stuff. So if you think about it, my wife is sensitive, so many realms, but you know, if she swims in cold water, her lips turn blue. That doesn't mean she's hypoxic. It means she's cold, maybe a little hypothermic. So you can have that blue tinge not only because of hypoxia, you could have that because of something else. But somebody with a respiratory issue, somebody with an airway issue, somebody with poor oxygen exchange, hypoxia, cyanosis is typically a sign that is of severe hypoxia. Cyanosis can happen for other reasons, but hypoxia is closely associated with. So great discussion, good. So infants, right? Infants, in infants, usually early response to hypoxia may be bradycardia rather than tachycardia. So in infants themselves, when they start getting poor oxygen exchange, their heart's going to do something different rather than breathing faster. Whereas with adults, a lot of times their heart may not change, their respiratory may change. So if you have an 18-year-old asthma patient, you know, he may be breathing or she may be breathing faster and faster. You got an infant who's having something happen that they have hypoxia, their heart rate may change. Patients themselves with any signs of hypoxia require immediate assessment. We got to figure out what's going on. They are not getting good exchange. They are not getting this oxygen they need to their cells. That's a problem. That's somebody who we need to take care of. There needs to be some intervention there. So those are things to kind of think about.
Is there medication to avoid, or like the best of its abilities, avoid hypoxia, even infants and adults, or is that all just like when it happens, you know, you got to
Sure.
get, there is?
It depends on why the hypoxia occurs, right? Is the hypoxia because they're exposed to carbon monoxide and they're not getting the gas exchange because they're in a building where the furnace is bad? Or is it that they're getting hypoxia because they're an asthma patient and they're not getting that exchange? So is there medication for asthma patients? Absolutely. There's long-term acting steroids. There's long-term medications that help overall. There's rescue inhalers that help when there's an acute exacerbation, or, you know, getting the person out of that place where the furnace is bad. So it depends why the hypoxia. There are medical conditions that are treated by medicines to fix that hypoxic issue, but it depends on why they're getting that, right? So hypoxia is just there's many different causes of hypoxia. It could be airway, could be inadequate breathing, could be inadequate delivery of oxygen to the cells, could be a lung or airway disease, asthma, emphysema, right? The inhalation of toxic gases, carbon monoxide. So it can be a whole host. So hypoxia is used for all these different things, and basically it's a term that they're not getting what they need, right? Now it could be for any different types of things. Think about a drug overdose, right? A drug overdose suppresses the respiratory center, right? Somebody taking too many narcotics, shooting up with too much morphine, too much heroin, or other type of narcotics, the drug's not going to kill them, right? What's going to kill them is that they're going to shut down their respiratory drive. They're going to shut down their ability, their respiratory center. So then they stop breathing. Because the drug shut down the respiratory center, they stop breathing. That's what kills that person. That's what causes long-term brain damage, right? So it's that piece that we need to be cognizant of. And you as an EMT, you can fix that, right? Somebody with an overdose, you know, I don't want to go too far down this path, but so that's really what we're looking at. I'll talk about that later with medications or some other disease. But think about why. And for hypoxia, it's a generalized term. It can be because of mechanical, it can be because of toxins, it can be all these different things. So just because somebody's hypoxic doesn't mean, oh, I have an asthma patient. No, you have somebody who's hypoxic. Now we got to be a detective. Now we got to figure out, why are they hypoxic? Is there a certain condition? Is there something I need to fix? Am I not even in a safe place because there's too much carbon monoxide, and do I need to get the hell out of here, right? So those are some of the pieces that we need to think about. You need to think about as you kind of progress and move forward. All right, I'll get off my little soapbox, but that things to think about. Hypoxia can be because of cardiac, because of respiratory, because of nervous, because of all these different types of things. But it is an important term to understand. Mild to moderate signs of hypoxia. Mild to moderate would be tachypnea. What the heck is that? What is that? Adam, what do you think?
I'm honestly not sure.
Okay, Jessica wants to help you out.
Does that mean like tachy means fast, so like a fast heart rate,
Close. What does
fast breathing rate?
breathing,
Fast
right?
breathing. Yeah, because
Absolutely.
that's like apnea, so it's breathing. Tachy. How do we say it? Tachypnea.
Tachypnea.
Is it like
Tachypnea.
raspy
So
breathing?
breathing fast.
Breathing fast. Yep.
Okay. Correct. Thank you.
Sure. So that's it, right? Tachypnea is breathing fast. And if you use the same logic a little bit further down, we have tachycardia. Well, tachycardia, cardia is fast breathing. That's why they go through the book. They spend a few pages talking about breaking down words and tachy. We just like to keep things complicated in medicine. It's just a pain in the bum. But when you think about it, tachypnea, tachycardia, two terms that you should know, right? One's breathing fast, one's breathing slow. We don't want to talk just normal English, breathing fast, breathing slow. We want to throw in these technical terms. But if another healthcare individual talks to you, if you go in to talk to the doctor or what have you, you can say breathing super fast, sure, and that's fine. Plain English is always better than if you don't know the word. Be very careful not to screw that up and say the wrong word. So if you know it, fine. If you don't know it, then don't say it. Speak plain English, right? Dyspnea. What's that?
Is it like shortness of breath?
Absolutely. Great job. Shortness of breath. So they're breathing fast. They have shortness of breath. Pale, cool, clammy skin. What's pale, cool, clammy skin? What's another term for that?
Cyanotic.
Blue, right? But pale itself. And when I'm thinking cool, clammy skin, what are you going to be thinking of? Sometimes they're diaphoretic, right? Cool, clammy skin, they're kind of wet, they're diaphoretic. So sometimes you'll hear somebody say or describe someone as diaphoretic, they're sweaty. But is it cool, clammy skin? Is it whatever it is? But mild is more typical that it's cool, clammy skin. Tachycardia, we talked about, that's increased heart rate. Restless, agitation. Somebody who's hypoxic, you can't breathe. You don't feel like you can breathe. You feel distress, and because you feel that, you're going to be anxious. Sometimes they're anxious to the point where they're just not nice people, right? But they're agitated. They have something going on. Sometimes they just can't sit still. They're just agitated. Then somebody said earlier, right? Altered mental status or disoriented. The disorientation, confusion. That's going to be across the board for so many different medical things. Anytime somebody's not acting right, or somebody tells you that they're not acting right, that they're disoriented, that they're a little confused, and they don't live, granted, little May, who's in the nursing home that has Alzheimer's, maybe she's pleasantly confused all the time. That's her normal baseline. But if there's a change in that confusion, that disorientation, that responsiveness, on altered mental status besides their norm, that should put a gong in your head and say, boom, there's something going on with this patient. Could be because of alcohol, could be because of drugs, could be because of some respiratory condition or some heart condition, or some other medical condition. But disorientation and confusion or altered mental status, you're going to see across the board with so many things, right? But this will be just a touch of they're a little confused or a little disoriented, not so much. And then you go to the next one, right? And we have severe hypoxia. Well, just increase everything we talked about. This is where they start turning blue or they have cyanosis, right? They got an increased heart rate, an increased respiratory rate, an increased shortness of breath, even more than what they had before. Sometimes it'd be so bad that the head starts to bob, right? They'll have some confusion. They'll have a slower reaction time, the altered mental status. Now, technically, right, disorientation, confusion, that's altered mental status. But it gets even worse, right? That it just gets even worse. So you have altered mental status. And altered mental status, better put off a gong in your head that something's going on. Something's wrong with this patient. Is it respiratory? Is it any number of things? Could be, right? Falling asleep, droopy eyelids, they just look like crap. They're sick. When you walk through the door, right? And I work with my medics and I work with EMTs and we talk, you know, when you walk through that door, you're doing a couple of things. Are they sick or are they not sick? Is it something that we got to scoop them up and get going because we need to correct the problem? Or do we need to correct the problem right here and take care of that? But when I walk through the door, in my head, first thing I do when I put eyes on that patient or even talk to their bystanders and then put eyes on that patient, first thing I'm doing in the first few seconds that I meet that patient, are they sick or are they not sick? That affects how I'm going to treat this call. Am I going to get my crap together, get what I need and get the hell out because they're going to die before I get to the hospital? Or am I going to take a few minutes, see what's going on, not a big deal, go yada, 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 not huge. Still be cognizant, still be professional, still do what you need to do, still treat your patient. Don't be, I mean, we're doing this for patient care, but you want to think about, are they sick or are they not sick? Okay, things to really think about. Other things physiologically, that capillary, alveolar capillary exchange, that external respiration piece of it. You know, as we kind of look at these pieces, oxygen-rich air enters the alveoli, the inspiration, the blood moving, in there is deoxygenated, it goes in, it picks up oxygen, offloads carbon dioxide, goes down through the process. We really want to start thinking about, you know, what happens there. Hemoglobin, is really important piece of this, right? So hemoglobin that's found on the surface of red blood cells, that picks up the majority of oxygen. So if you got low hemoglobin, you can have some problems, right? The majority of oxygen, about 95% of it, is carried by that hemoglobin, and it carries it throughout the arterial systems and capillaries of the body, right? So it's a big piece. Carbon dioxide is exhaled at this point, right? It goes from the alveoli to the out and out the lungs. In, out, exchanges, high levels, low levels, different cells, different processes, okay? Good? Good.
Yes.
All right. When we think about physiologically, right? When we think about physiologically, the pulmonary ventilation, exhalation, and internal respiration, right? When we start thinking about these types of things, a disturbance in that pulmonary ventilation or oxygenation, external respiration, internal respiration, or circulation all lead to hypoxia, right? They lead to stuff is not working appropriately. The conversion of it also can cause either aerobic or anaerobic metabolism. Those are two terms that you want to start thinking about. Anaerobic metabolism is often associated with insufficient energy production. You're going to have a buildup of lactic acid, right? It's a short, anaerobic is short. Aerobic is typically longer. Typically sitting here, it's a process where it's an aerobic process, right? Anaerobic, if you think about it, that's where people are pumping hard and doing things really quickly, but it's not sufficient, right? It's a high amount, but you're going to use up a lot of things. You get more lactic acid, and long term it can have some complications, right? So yes, people train, people do certain things, that type of stuff, but really start thinking about that. Somebody's anaerobically, somebody's working within that, they can have some severe problems in storage of energy and different things like that.
I wanted to let you know, I got a message from Rose. She texted me and said that her laptop had just died, and she's gonna charge it and log back in as soon as she possibly can.
Okay.
Okay.
All right. You could text her back saying she could call in too, I think. So there should be a number that you can call in on her phone or click on from her phone too. But yeah, that's fine.
Okay,
So
I'll let her know.
thank you. So disruption, causes of this disruption, causes of some of these problems to think about, right? We know that it could be mechanical, it could be diseases, and it could be obstructions, right? So mechanical, what are some examples or some things that we think about mechanical, a disruption, a mechanical disruption? What does that look like? Or give me an example.
Would that be something with the mechanics of like the way the heart is sending out messages, or like the way the actual mechanics of your lungs, they're working, like something's off,
Right.
like off in like the perfusion, or off in the
Or
way
mechanical,
they
so you're
breathe
right.
out.
So you're right that mechanically something's off. So typically mechanical, that there's a disruption of the airway because of patency, because of some allergic reaction, could be a mechanical process, right? So you have major swelling of the airways. That mechanical change can be because of massive amount of swelling, could be because of burns, could be because of trauma, because somebody got so much trauma that it's affecting how things happen, right? A foreign body airway obstruction, so somebody choking, that's a mechanical issue that you're not getting oxygen that you need. So that,
Inhale something, would that be mechanical too, like inhaling fumes?
yeah, because if you inhale the fumes, what happens? That may cause burns, it may cause that inflammation, that swelling. So that swelling, that disruption, that mechanical affects the mechanical process, right? Versus when we look at it, diseases are like pneumonia, pulmonary edema, drowning. They all hinder that piece, right? And obstructions themselves, if you think about it, may be more so towards blood flow. Pulmonary embolism, tension pneumothorax, heart failure. So obstruction, heart failure, the blood's not pumping right, so then you get fluid buildup, and that's going to obstruct. Cardiac tamponade, you get taken and swelling around the heart that the heart doesn't, that the heart is restricted and can't pump effectively. That's going to cause obstructions within the system, which then will go into the whole respiratory issues as well. If you think about pulmonary embolism, you got something stuck somewhere that they're not getting that exchange. It's obstruction
Like
is
clot
that.
in your lungs?
What, a clot in your lungs, right? Yep.
Would pulmonary fibrosis be a mechanical issue, or would that just be labeled as a disease because it causes the scarring of the tissue that needs to move in order to efficiently get air into your lungs?
It's a great question. I would almost classify that as both, right? Is that you got that inherent disease, but that disease causes mechanical, long-term mechanical changes. So that's a great one. I mean, I guess I would say it's initially sparked by disease itself, but yeah, that's okay. At the end of the day, doesn't matter. You have certain problems that you need to fix or change or maintain. But yeah, that's a great question. I'll have to think about that. You guys are good. So let's talk a few seconds about anatomy of infants and children. And I think it's important because number one, what happens when you get a child or infant? Typically, what happens to you as a provider? Your heart rate's going to go up, your sphincter's going to tighten a little bit. You know, people are, and why is that? Well, because we don't see them all the time. Majority of the time we deal with adults. Because we've destroyed our bodies, where we get sick more, we do whatever, right? Here, hold my beer. Stupid things. Kids don't hopefully do that, but they get in accidents, but we don't see them as often. Number one. Number two, a little bit different, right? They have a lot of similarities, and we need to recognize that they have a lot of similarities, but they, however, do have some differences as we think about that. Their anatomy, physiologically, a little bit different, right? They're not exactly the same as an adult. When we look at it, right, we do have structurally a little bit of a difference. We typically have in a child, the tongue takes up more space, which then can be a little bit more problematic when we're managing that airway, right? You have a little bit change where that epiglottis protrudes a little bit further in, again, making some challenges. The trachea is typically narrower and softer and more flexible. The cartilage itself is a little bit less rigid and not as developed. So just structurally, there are a little bit more challenges. And the big thing to think about, proportionally, that big old fat tongue that we have, that I have flapping around right now, right? Proportionally in a smaller child is going to actually take up more space. So it is important to kind of think about some of those challenges, not to freak you out, but things to think about. We also know with an infant, if I'm putting in an oral airway in an infant, I'm going to do it a little bit differently than I'm going to do it in an adult, right? I'm going to slide it in more anatomically correct. I'm going to throw in a tongue depressor, push it down. I'm going to throw in the airway that way versus doing what you just were taught with an adult to go in and flip it around. So, because you got to be careful of that palate. The palate is more pliable because they're still developing and changing and all that wonderful stuff. So they're small, you're dealing with a smaller structure, but you're also dealing with different proportions within those structures as well. So things to kind of think about, right? Things that make you go, And it's something that we don't see a ton of. So just recognizing right now, we'll talk about pediatrics later. We'll probably show a couple of videos too, but you know, later on in the program, we'll talk specifically about pediatrics, but realize that anatomically, structurally, there are some differences that we need to be aware of. One of the big things when we're thinking about airway is airway assessment. Do they have a problem with the airway? Do we know what's going on, right? Some airway functions and considerations. You know, are they alert, awake, able to speak? Are they breathing normally? Are they talking whole books like I am right now? Or are they to the point where they can't breathe and they can only get out 1 to 2 word dyspnea? 1 to 2 words, shortness of breath. That's a patient that you have an issue that you may need to figure out what's going on with them. So things to kind of think about with that as well. When we're talking about this, and you know, you really want to think of what's going on. Is there an altered mental status because of some airway compromise? Are they getting hypoxic? Are they cyanotic? What else is happening with them? Okay. So when you're thinking about this patient here, this is a burn patient. This is going to be a whole big mess that we need to figure out of what's going on. Not the easiest picture to look at, but we need to start thinking about airway. This is a really tough call. And how do we maintain that airway? If there's that amount of burns on the exterior, what the heck is going on the interior? What do we need to manage? And what are we going to have for swelling? And how are we going to manage that? Really, really difficult call. You can't fix it. You're not going to change it. You need to get them to the appropriate facility where they can maintain it and figure it out. You know, sometimes with trauma patients, we have to take and move forward and get them where they need to be. I'm not going to fix a trauma patient. I'm not going to fix a burn patient. That injury has happened. What I need to do is manage what I can and get them where they need to go so then they can start working on some of those problems. So things to really think about. That airway, you know, is that airway going to be patent? If it's not going to be patent, how do we make it patent? If there's an obstruction with food, swelling, vomit, you know, what do we need to do and how do we need to do it? We can't change that swelling that's going to happen in this airway. Hopefully we can mitigate it the best we can, but hopefully we can get them where they need to go in an appropriate fashion so that they can manage that airway. It's going to be really tough as a BLS provider, even as an ALS provider, to manage this airway. Things to kind of think about. Mental status a lot of times will correlate, you know, with somebody who's not breathing, those general issues and problems, that's going to change their mental status, altered mental status. bad thing. Something is going on to make them sick, okay? When we think about sounds, when we start thinking about sounds and what's normal, what's not normal, even the upper airway, when we listen to lung sounds, we're listening to the lower airways. We're trying to figure out what's going on. Sometimes we'll have some young ones that we're dealing with that we have upper airway sounds that we want to hear, snoring, gargling, stridor. All those are more upper airway sounds. That's what we want to listen for. Sometimes you don't need a stethoscope to hear some of these things. You're going to hear it when you walk in the room. That's when you do your initial assessment. Are they sick? Are they not sick? What's going on? Upper airway sounds that you're kind of hearing and listening for: snoring, crowing, gurgling, stridor. Snoring, typically upper airway. It's really because of obstruction, typically head, tilt, chin lift, those types of things. Crowing sound like basically a cawing type of sound. Gurgling, stridor, harsh pitch type of sound as well. When we're talking about managing the airway, one of the things we're going to do is we're going to open the mouth. We got to open that airway. And you guys did this the other day. How were you shown to open the airway? Evan?
The head tilt.
Head tilt, chin lift, that helps to open that up, right? But how else how are we going to open that mouth? How are we going to open somebody's mouth?
What's an OPA?
Okay, but how do we get the OPA in?
Jaw maneuver.
Jaw thrust?
Jaw thrust?
You could jaw thrust, you know, if you
I don't think we learned that yet.
okay. But if you think about it, you got to open the mouth. Cross finger technique is one, but I'm not a huge fan of putting my fingers in somebody's mouth, right? But sometimes you got to grab that jaw and open up that mouth to get the OPA, and you got to open up the mouth, right? So cross finger technique is one that they'll show you in the book, right? Where you place your thumb and open the incisors that way. Again, some people don't like to do that. Sometimes I'll grab the chin here and I'll open up that if I can. If I can't, you know, if you're trying jaw thrust and opening up there, you grab a hold of the mandible here and you push down like that, you can open up the mouth. But the first thing you gotta do is you gotta open the mouth. You wanna take a look in, see what's going on, see if you see any swelling, anything else with that. Now, an airway itself, you're absolutely right? We talked about head tilt chin lift maneuver, and that's where we crank that head back and we open up that. Typically, we know when somebody's laying supine and when they're flat on their back, what's going to be the most common airway obstruction? A big old fat tongue, right? So we need to open up that airway. Sometimes just opening the airway, they'll start breathing. Ding, 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 you win, right? That's good, right? You don't have to get really aggressive, but you need to really open up that airway. You're going to open that up, and typically when an adult, that chin is going to be pointed up towards the ceiling. We're doing this when we don't suspect some type of C-spine injury or some type of spinal injury, not just C-spine, but a spinal injury. We're going to be doing a maneuver that we'll talk about, right? Head tilt chin lift, infants and children, a little bit different, right? I'm not going to take their chin and point the chin up towards the ceiling. I'm going to put them more of a neutral. I may actually take and pad. We know that that infants and children, what are they? They're weeble wobbles, right? They got the big old fat head and their body's kind of growing into it. Versus an adult, right, where we got larger shoulders, we got a head that's a different proportion. So typically, when we try to put somebody in spinal neutral position for an adult, we're actually putting a tiny bit of padding underneath the head to put them into a neutral position. Whereas for an infant or a child, it's the exact opposite. Usually their shoulders are smaller and their head is bigger, so we're actually padding underneath there. Well, things to think about when I'm taking and managing that airway is that I'm not going to take and tilt that back as far because I'm not going to have to go as far because their head's a little bit bigger. Maybe I need to pad underneath the shoulders and the lower body to make sure that I get in a good neutral position. With infants, typically we're in a sniffing position. We're just tiny bit going back. We're not cranking back like an adult, because if we crank back like an adult, we're actually going to do more damage, right? Not that we're going to do damage, but we're going to close off the airway because we're cranking it back too far. We don't want to hyperextend. we want to consider putting some padding underneath the shoulders and the lower extremity, and we want to put them into a neutral position. Typically, when I think about it, adult, I take that chin, throw it up towards the ceiling, right? Child, more so nose, mouth. And infant, just that sniffing position. That's where that's my money. That's where I want to take and go, right? So those are things to kind of think about. Because their airways underdeveloped, the structures in an infant, we don't want to take and overextend that. If we overextend, we can actually obstruct the trachea. Like I said, we can make our lives even more difficult than it is, right? Head, just that neutral position is what we're looking for. Okay. All right. You want to take and be careful, right? Oh, it's a great drawing opportunity. Love it. You want to be careful with this right here, right? This is soft and pliable. When you grab a hold of that chin, you got to be a little careful not to put too much pressure there. You put too much pressure there, you can actually, again, cause airway obstruction and make your life more difficult. It's hard to do, right? It's hard to do because what's going to happen, again, you're going to be stressed a little bit. Your heart rate's going to be up. You're going to get a little bit of that adrenaline rush. Take a deep breath, relax, go through, remember, keep calm, understand what's happening, and go from there. These are going to be stressful calls. Adult, child, infant, anything when you first start, where somebody's truly sick, it's going to be a little bit tougher. Okay, you got to take a deep breath, got to relax, got to go through and do that. Remember, it's their emergency, not your emergency. Yes, we want to make sure we take care of them, but we also want to do it most efficiently. You're going to do it most efficiently if you actually take and slow down and do the right thing. Jaw thrust maneuver. You guys have already talked about that, right? You already kind of talked about that. If we suspect any spinal injury, if we suspect something going on, we want to do that. You're going to grab a hold of that mandible. That's going to help open up that mouth, right? And we're going to help do that. This is not an easy maneuver. This is not something that's super simple to do. Best way to do it from the head. You're going to use yourself, use your body mechanics to do that. Jaw thrust with an infant, same thing, but you want to take and really understand that this is going to be a little bit less. You're going to have a smaller structure to deal with. You're going to lift up a little bit less. We don't need to do a huge thrust. We want to make sure that we're opening that airway, absolutely, but we got to do that. As far as, positioning the patient for airway control, that's why we have the airway seat in the front at the head. You can manage a lot from the head. Now, sometimes because of what's going on, because of the situation, it's going to be very difficult, right? And if we're thinking about protecting that patient long-term wise, do we need to put them in a different position, the recovery position? You'll see this in your book. If they're going to be vomiting, they're going to be doing X, Y, and Z. I don't want them flat on their back in a supine position, because what's going to happen is they're going to aspirate all that fluid, that vomit, that whatever, right? So that's things to think about. The other thing with airway, right? Don't forget we have different types of patients. We have pediatric, we have child, but let's be honest, we also have obese patients. If you throw an obese patient flat on their back, they're going to have that weight. They're going to have that pushing down on their chest. You could drastically affect their process too and decrease that. You get somebody who's 500, 600, 700 pounds and you're like, oh, that's really heavy. We have those patients, and you put them flat on their back, you could really complicate the issue. Treat your patient, understand what's going on, and figure out how you can best service them. Recovery position, no supine injury, you could place them in that, but just kind of keep that in mind as well. Standard precautions, thinking about suctioning. This is a skill that a lot of times people forget about, but this is such an important skill. It's a skill you can do as an EMS provider, as a BLS provider, and it helps to maintain if they got obstructions, they have whatever. What's the name of that suction device that person has in their hand right now? Does anyone know? Oh, Jessica. I muted you. Hold on. I'll unmute you. Okay, Jess?
Is that a catheter for a suction or a
What
yanker?
catheter?
It looks like a catheter to me.
French tip catheter, right? Yeah, very good. So French tip catheter, Yankauer is a little bit different, and that's more rigid. Typical standard for EMS that you're going to see on our suction kits when you walk in is typically will carry a Yankauer. This here typically we'll use differently. But when we manage the airway, right, we need to make sure that we have the appropriate PPE, that we actually have eye protection, mask, gloves, because we have that. Now, obviously with COVID, we made things super challenging because, and to be honest with you, before COVID, we really sucked at PPE. Hopefully we're better now, and I think we are in some respects. But things to kind of think about. Suctioning itself, we have a couple of different units. Well, all of our trucks have a fixed suction unit within the truck, right? So we have a fixed where in our office, we got it right there. Fantastic. But we're not always in our office. So sometimes we need to have our portable suction. Portable suction only works if you actually bring this thing out of the truck, right? So understanding if you get called for certain things, understanding that if you get called for a cardiac arrest, I'm going to want a portable suction unit in there if I'm working a code, right? If I'm going to intubate the patient, I'm going to want a portable suction unit in there. Are we very good at bringing them in all the time? No, we're not, right? Portable suction unit only works when you actually got the unit with you. Granted, every single call, you don't want to be carrying 18 million things, but it is something to think about. If you're going to be managing that airway, you're going to want suction, and you're not going to want to send somebody running out to the truck when you're sitting there and they're drowning in front of you. Pre-plan, figure out what you want to bring, figure out how you're going to practice, but it is something important. I think we do a not so great job with some of this sometimes, myself included, but it is things to think about. When we're thinking about the portable suction, you know, batteries, charging, doing all that type of stuff, we want to make sure that we got all these things ducks in a row. Are we going to use a rigid catheter? Are we going to use a soft tip catheter? Those are things to kind of think about. Here's our Yankauer, the steadfast catheter that we use all the time. It's on your trucks. This is what we use majority of the time. You have the French tip, which you'll see out there. In the Yankauer itself, I think there's some better difficult airway suctioning things. I think the Yankauer specifically, sometimes it's real hard to pick up chunks. It's hard to do different things. It is a device that we use. Sometimes there's a little hole in it, so you gotta understand which one you have for the Yankauer or the ridge tip catheter. You know, is there a hole that you need to include? Is there not a hole? You got to understand your device and how to use it. So make sure as you go through class, you figure that out, but also as you go through. Let's see if the video actually works, right? It might be a little choppy, I apologize, but let's see how this kind of goes through.
Patients may require suctioning because of secretions, vomitus, and blood in the airway. We can use a portable suction or one of our own core suctions on the back of the ambulance. For demonstration purposes, I have removed this from the bag in order to show you the functions of this portable suction unit. Suction tubing and some catheters like the Yonkers or rigid tip or the soft tip catheter seen here can be used. These are the disposable portions of the suction unit. Portable suction unit has a container that will hold the secretions and vomitus, as well as a battery and a switch that will allow suction to be turned on. I will first demonstrate the Yonkers or rigid tip suction catheter. In order to utilize this device, we must also measure similar to that of the oropharyngeal airway. We measure from the tip of the ear to the corner of the mouth. I'll use my index finger in order to mark this off. On many of the Yonkers or rigid tip catheters, we have a small hole which will allow you to control suction being turned on and off. After we have measured this, we use again the cross finger technique to open the airway. We turn on the machine, insert down to the level of the finger, apply suction, and in a sweeping motion, clear the airway. Suction should last no longer than 15 seconds, or as long as you can comfortably hold your breath. The soft tip catheter can also be utilized as well. Removing the rigid catheter in place of this will come in many different sizes. The suction may be utilized in the mouth, the nasal airway, and in some instances for a tracheostomy patient, suctioning this out as well. I will now measure from the tip of the ear to the corner of the mouth. Turn on our suction. Insert. Apply suction in a sweeping motion. Remove any pump. As with any other devices, personal protective equipment should be utilized. It's very important to note for suction, you should also wear a mask as well as gloves.
How'd that come through? Bad, good, indifferent,
Horrible.
horrible? Sorry.
Yeah, I couldn't really hear it and it was skipping so much.
Okay. All right. Well, some of the key things, right? When you're thinking about this, you want to measure 10 to 15 seconds. He said 15. Some of the books will say 10. I usually say 10, but 10 to 15 seconds. You don't want to suction for 2 minutes straight, right? There again, if you get Mount Vesuvius that's coming out, sometimes we suction a little bit longer. When you're out there in the field, maybe you'll see that a little bit longer. So just realize that textbook, test-wise, 10, 15 seconds. He talked about the rigid tip. He talked about the French, which you see here. And you'll get some more hands-on in class too. Measure. Anytime you're going to shove something down, I like to measure. I do like to use the finger technique, which he talked about, where I'm going to measure. I'm going to find that point on the rigid tip, and that's where I'm going to go each time I'm suctioning. There's their technique there. If there is some of the rigid tip catheters, the Yankauer, a traditional Yankauer itself has a little hole on the top, so you're going to occlude that hole in order to have the suction be applied. So you can turn on your machine, unclude that hole, put it in, because we suction on the way out. We don't suction on the way in. So you're going to place it, then turn on the suction one way or the other. If you only have a rigid tip that doesn't have on-off little hole to make it suction or not, then typically you would insert it to where you measured, then turn on the unit and suction on the way out. Okay? No more than yeah.
Do you put it under the tongue or anywhere inside the mouth?
Usually I try to have the tongue down, but anywhere inside the mouth, right? Because we're suctioning, and I'm gonna go. Yeah, I can't go. If it's under the tongue, I only have a small space, right? I'm suctioning that airway, so I'm gonna go beyond that and suction everything down that I can.
So you have to move it or just leave?
You may have to, if they're completely unconscious and you're suctioning and you're doing what you can, you may have to take and hold that tongue up out of the way, whether or not it's with something else or moving it or manipulating it with the Yankauer as you go in. You may actually have to do that, sure. Yep. And again, that no more than 15 seconds, right? Like I said, some you'll see 10, 15, but no more than 15 seconds do you want to take and apply that. and then you need to do that. Holding your breath, comfortably breath, that's not yet necessarily a really good gauge, plus you're probably going to be a little bit ramped up. So 15 seconds, keep that in the back of your brain, right?
Is
and
it
we
also
suction.
for infant?
What's that?
Infant, is it 15 seconds also?
Yep. Infant, child. Sometimes a little bit shorter depending on what you're clearing and that type of stuff, but yeah, 15 seconds is a good rule of thumb. Okay.
Thank you.
All right. Some things to kind of think about, right? 15 seconds. Again, sometimes this can stimulate and have other issues. Decreased heart rate. If you trigger some various responses, different things. So you could, if you get some major decrease in heart rate, that type of stuff, you may need to stop suctioning and actually start ventilating because their heart rate's dropped or something has changed and that type of stuff. So making sure that you clear, you sweep, you get any foreign material out. You know, in the yank hour is fine for fluid. It's fine for water or blood or that type of stuff. It really not very effective for big chunks. Big chunks or chunky vomitus and that type of stuff, it doesn't work really well. So you may have to clear the airway manually or with something else. So you may need to take in finger sweep. You may need to do something else because that yank hour is not going to pick up that 1 inch by 1 inch piece of steak, right? So some things to kind of think about, which will kind of fly through this because you guys have had your hands on some oral airways. I know you have because I've interrupted a few times, right? So oral airway, one of the critical tools that you have as an EMT. And it's a critical tool because it's going to get that big old fat tongue, that muscle up out of the way. That's how you're going to be able to manage or take control of that airway. That is your tool, right? That's one of your tools. Thanks for the feedback on the video. Sorry about that. Okay. So oral airway, different sizes. Okay, you can have some with the ridges in there. Sometimes there's a little hole. Either way, doesn't matter, right? Oral airway. So some manufacturers have them a little bit different, but they're different sizes. You want to make sure you size and get the best size that you can. Not everybody is a certain size. Not every airway is exactly the same. You want to measure it to that person and get the best size that you can. Too big, cause an obstruction. Too small, you know, have an obstruction because it's not doing its job. So try to get the best size, right?
What if there's someone, what if there's someone like in the middle size? Is it better to go smaller or better to go larger? If there's really like just in the middle.
Best guess. Do what you can. If you get a good response from whichever airway you're using, great. Sometimes I'll try to go a little bit bigger, especially if there's holes that I can do that. What I'm concerned, if you go super tiny, is not going to hold that tongue. The whole function that you're trying to do is hold that tongue out of the way, right? So that's what you're trying to do. Now, if you use one way too big, you're going to shove it in the wrong hole, and then it's going to just occlude because it's a big old piece of plastic. So that's the tough point. So you want to take and size it the best you can. It's not an exact science. It's kind of what makes sense. We do know that most of the time, if you're using a 3-4 for an adult, that's typically the sizes that you have. Some services in our jump bags, we carry 3 OPAs, and that's all we carry in our jump bags, unless it's a pediatric and we have a separate pediatric. So typically among those 3 sizes, you're going to get most adults. So good question. Another video, not gonna worry about that. It's basically, you guys have done that, plus it's gonna be probably pretty choppy. Nasopharyngeal airway, throwing that nasal in. Again, that's curved, that's soft plastic. The biggest thing is that bevel should be pointed towards the septum, which is the thing in the middle of your nose. That bevel should be towards that initially, and then you'll have to, they're designed to go in the right. Typically the right is a little bit larger. Typically the right is what it's designed to go in, but you can go right or left. You just change it a little bit and make sure the bevel is pointed towards the septum initially. Then you'll rotate it around. You're gonna have to lube them in adults typically. You gotta get a little bit of lube on them to make it go through without too much problem. Okay. Some people could tolerate, some people can't. You can use if you can't use an OPA because of gag reflex, you can still use an NPA. So you can do this in a live person. Tommy did it the other day, right? This video here is just them doing it inserted. Military loves to do different things because you can. So they actually practice putting in nasal airways in each other and stuff. That's kind of fun. When we're thinking about assessing the airway, right? How do we assess the airway? What do? Well, we got to take and look, listen and feel, and also take. We got to listen for lung sounds. Pulling out your stethoscope and you're listening. What are you listening for? You're listening for something different. You're listening for some type of breathing. So could it be wheezing? Could it be that there is no breathing? You know, sometimes that's what you're listening for. Is there even normal respirations? You can hear them breathe in and out. Is that actually taking place? Is it equal? Is it on one side but not on the other side? Is it shallow? Is it deep? These are all things that you're not only looking, listening, and feeling, but you're also oscillating as well. You're gonna have to listen for lung sounds. You want to listen to as many normal as you can. That's really important, right? Not sure how this will play through, but we'll try it. This will probably be a little choppy, but basically they're going to take you through. Let's keep going through this. I'll check and see if Tommy's uploaded it. If not, we'll get some of the different sections on there. Adequate breathing. What is adequate? What is normal breathing, right? So what's the rate, rhythm, quality of breathing? Normal breathing, anywhere for an adult, anywhere from 8 to 24 breaths per minute. Regular, full, equal lung sounds. That's adequate breathing. For little bebe here, right? They're gonna be breathing faster, right? Normal respiratory rate for an adult, anywhere from 8 to 24 times per minute on average, right? For a child, it's 15 to 30 times per minute. For an infant, can be anywhere from 25 to 50 respirations per minute. So smaller, faster is average, okay? Now, if I had an adult patient breathing 30 times per minute, I'd be much more concerned than an infant breathing 30 times per minute, okay? So you need to understand some of these things are important. Elderly patients typically have respirations right around 20 times per minute, right? That's normal for them, okay? When we're looking at the breathing, what we want to think about is rate, rhythm, quality, and depth. So when we talk about rate, we've just talked about that, right? When we're talking about rhythm, is it regular? Okay, there are sometimes different patterns. Different patterns can give you some indications as far as what's going on. For you, as a brand new EMT, what is the rhythm? Is it regular? Is it irregular? Is it fast? Is it slow? What's going on with that? Then the next thing to think about is what's the quality, right? Is it equal bilaterally? You listen on the right and listen on the left, and you notice that one is not the same as the other. That's important. That's important to know as well. Okay. When the other thing, when you're thinking about quality, is there excessive accessory muscle use? The inhalation, exhalation, those are important things to kind of think about. Depth, tidal volume, you know, did chest rise fully? Does it not? What else is going on with them? Inadequate breathing, right? Some things to kind of think about here. Inadequate breathing can be lots of different reasons. They can be oxygen exchange, can be different cells, can be different things with the heart or brain or different types of things. But typical signs of inadequate breathing, think about this. What position would I say this patient is in?
Tripod.
Tripod position, right? He is in a tripod position. That is a term you better know. You gotta have to know is when somebody says tripod, it's not what I set my camera up on, right? It is how your respiratory patient's gonna sometimes appear. That's important. This here, that he is tripoding. You can see here, here, and here. Sometimes they'll be standing with their hands on their legs sometimes, but you'll see them trying to tripod. He's trying his best to get that air in and out. The other thing I'm going to say here too, if you look up in this area, you look right there by his jugular, he's got jugular vein distension where these veins are popping right there. But also I would say he's got really good retractions going on too, which means if I removed his shirt, you're going to see the retractions in his breathing. You're going to see that skin getting sucked right down. He is working hard to breathe, right? So when we think about that, again, we want to think about rate, rhythm, quality, and depth. Rate, is it too fast? Is it too slow? Tachypnea is excessive or fast breathing. Bradypnea is where they're breathing abdominally slow, right? Rhythm, is it regular or irregular? Irregular may be something with a brain injury or some other medical illness, right? Even diabetics sometimes will have an irregular type of breathing pattern. Most of them, irregular breathing patterns also produce an inadequate rate, depth, and quality as well. Quality, when we're thinking about quality, that's where we loop in our breath sounds, okay? Are they decreased? Are they absent? Are they moving good air volumes? Is the chest wall rising and falling? That's all within quality of breathing, right? That's what we're checking there. Depth, is it equal? Okay, but is it adequate? Okay, all important pieces as we assess our patient. Making that decision, are we, let me clear off that screen for you, but are we making that decision? When do we ventilate, when not to? Are they sick, are they not sick? When are we going to take and ventilate? That's really hard to determine. If you wait too long, it's going to be too late. You'll be chasing your tail the whole time, right? Things to kind of think about is, adequate respiratory rate, and adequate tidal volume equals adequate breathing. There are different things as we kind of look at, if they're inadequate respiratory rate, inadequate volume, all these types of things. Really need to start assessing our patient and looking at that. Assisted and artificial ventilation, probably one of the most important things when you're ventilating a patient. That is one of the most important things you can do as an EMT, right? It's one of those life-saving skills. If they are not breathing, you need to breathe for them. If they aren't breathing, they're going to die, okay? So really important at the BLS level to be able to do that, to be able to maintain, to take that person's airway. An EMT can still manage an airway. You should be managing airways. And then sometimes you need some help managing that airway. So then that's where a paramedic can step in and help with that as well. Assisting ventilation, really not easy, right? But assisting ventilation, respiratory, that type of stuff, you want to take and help that. That can prevent further deterioration. Couple of options, CPAP, that's assisting ventilation. CPAP is not easy to put on somebody who's never had it before. One of the big things that we need to do is really coach it into them. And how does CPAP feel? Does anyone know what CPAP feels like? How would you describe it? Jessica? Oh, I gotta unmute you here. Go ahead.
CPAP, they're basically forcing air into your lungs to open up your the constriction that's in there that's not moving air. So it doesn't feel so good because they're forcing air into you to try to get you regulated.
Yeah. It's kind of like if you think about it, it's kind of like if you take your head, not condoning this all the time, but if you've ever been on a bicycle going about 20 miles an hour and you have your head up and that force, like when you're trying to breathe, if you take your head and you stick it out of a car going to anywhere from 20 to 30 miles an hour. I'm not telling you to do that. So if you get in an accident, it's not my fault. But if you were to do that, that pressure that you have, that feeling when you go to take a breath, that's what CPAP feels like. But you also have a big mask on your face and you got this thing around. So there's even more factors to that. But that force of that air and that type of stuff is kind of, that's what it's like, right? And so you take somebody who's short of breath and then you go to throw this on and it makes it even harder at first. It works. It works extremely well. It works extremely quickly. Within 90 seconds, you're going to see if your CPAP's working and if it's going through. But that being said, that initial coaching on somebody who's in respiratory distress that feels like they can't breathe can be very difficult. So that's really a big piece. And we'll do a lot more hands-on with that. Jess, did you have a question or still residual from the last one? You should be
No,
able to.
sorry, I just forgot to take it out.
No worries. Just want to make sure I didn't ignore you. Or assisted ventilation. And assisted ventilation is where you take that BVM and you put it on their mask and you try to breathe when they breathe. Tough to do. Back before CPAP, I practiced prior to having CPAP. And when I first practiced, it was just a paramedic skill, but that came on a few years after I started practicing. And the only thing we could do was try to ventilate with a BVM. Extremely difficult to do. And typically when we're doing that, that's the last stitch, because the next one would be is that they fill up enough, they go on unresponsive, and then I'm shoving a tube down their throat. So it's just, CPAP is an amazing tool that you have as an EMT is absolutely amazing. It's an amazing tool to use. It has definitely decreased the amount of times that I can intubate a patient because CPAP makes a difference and it does it quickly and effectively. And I've had patients that it's made such a difference that they go, oh, this person's not that sick at the hospital. They go to take off the CPAP and, okay, that's your fault, not my fault. I told you not to do that. So it is very effective tool that we have, actually a game changer. So when we're thinking about signs and symptoms of adequate ventilation, or inadequate, sorry, mental status. Again, it's this thing that we hear, right? We're hearing mental status because it is so true. Mental status across the board. Something's going on. Are they sick? Are they not sick? Are they mental? Do they have mental status? Really important thing to kind of think about. Inadequate minute volume, right? Excessive accessory muscle use, that they're using their muscles to breathe. So I've been yapping for a bit. We'll go a little bit further. I will give you a couple of minutes here. I know I'm kind of going a little long, but we'll be fine. So assistant with bag valve mask, you want to try to explain it to the patient. You want to put the mask over the nose and mouth. We're going to take and try to do that. This is not easy. It's more of an art than a science, and it's really working with the patient. Some patients who have had to have it in the past, who had good success, are sweet, great, work with it. If they never had it before and they have an acute exacerbation and they're really struggling to breathe, it can be really troublesome. Same as CPAP, right? Somebody's had CPAP before, they're COPD or they somebody who has fluid and they're CHFer, they fill up from time to time, have acute exacerbations, and CPAP's worked for them before. Sometimes they'll just like, give me CPAP, right? Yeah, I need CPAP. I don't have it at home and I need it. That's going to make a difference. They'll tell you what they need, and it will make a huge difference for them as well. Sometimes yes, sometimes no, all depends, right? Artificial ventilation, again, mouth to nose technique, that type of stuff. Normal ventilation versus positive pressure ventilation. Normal ventilation is that you're just going to take and go with the diaphragm contracts and makes the negative pressure cavity. Positive pressure ventilation is where you're actually trying to fight that and bag and force air into the chest cavity. Kind of zipping through some of these. You'll get some of these before, when you kind of go through BVM. Again, one of our biggest things that we use in the field when we're doing cardiac arrest, when we're doing these things. The bags that we have for an adult, are much more than what we ever need, right? How do you know that you've ventilated the patient appropriately? How do you know that you've got enough air in our patient? What am I going to tell you?
You'll see
No.
chest rise and chest fall.
As soon as you have that chest rise, right? As soon as you see that chest rise and fall, that's good, right? These bags that we have in adult BVM is more volume than they ever need. We actually have some places in this country, right, who are very aggressive with, and I'm not saying this is how we do it, right? We got to follow our local protocols and our medical directors and that stuff. But there are some places with high performance places with cardiac arrest that they actually, all of their units for, instead of using adult BVM, all of them have an adult mask, but a child reservoir in where they're doing it, right? Because that's enough volume. For cardiac arrest patient, you only need 300 to 400 mLs of air, and the big adult BVM that we have is so much more, right? So a lot of times when I'm working with firefighters, I'll say 2 to 3 fingers, right? Take these ones, put them up out of the way, do whatever, but just a couple of fingers when you're squeezing that bag is truly what you need. As soon as you see that chest rise, you have enough for this patient that we're working with, okay? If you blow in there, what's gonna happen, our little friend called gastric distension, you're gonna see more and more air go into that stomach. More and more air goes into the stomach. Well, at some point, it's gonna be full to the point where it's not going to be full anymore, which means you're going to have Mount Vesuvius, you're going to have some vomiting, you're going to have, at some point, you're going to get so much in there, I've been on calls where you see their belly rising and rising and rising, and at some point it will stop rising and you will get to see what they've had prior to, okay? So things to kind of think about as you kind of go through the process. Whipping through a couple of these because I'm running super far behind because I talk too much. Positive pressure ventilation, okay? And again, you've gotten some of this stuff, airway movement, pressure, all things to kind of think about as we kind of go through. BVM, you guys have already started doing that in class and talking about that. Standard precautions, we suck sometimes. Sorry, bad word, but we do. We stink sometimes because we don't necessarily have our safety glasses. Now we've gotten a little better with COVID because we have a mask, we have safety glasses, we have sometimes shields and gowns we've had to wear for quite some time. Gloves, we do good with gloves. Sometimes we overdo gloves. Sometimes we're touching way too surfaces with that. But we prior to COVID, we really stunk on the other aspect. Want to take and maintain and protect yourself, right? Especially now, especially forever, right? Is that if we're being aggressive with an airway and we're taking somebody's airway and we're doing that, we should have safety glasses on. I actually typically wear safety glasses on every call, right? And yes, people, whoa, that's a little dorky. Oh, okay, whatever. I really don't care. I'm old. It doesn't really matter to me. But if you look at your safety glasses at the end of the shift and how much crap is on there, that stuff goes into your eyes, your mucosa, that type of stuff. Theoretically, now on calls, we should be doing that because of COVID, because of all the other issues. But even prior to, we really should be doing that. All right, I'll get off that little soapbox of mine again. We talked about inadequate rates with breathing minutes. Neonates, think about what rate we're going to do. And a lot of times we're bagging people too fast. Your first initial reaction as an EMT, super fast, right? 9 times out of 10, I'm telling people, slow down, slow down. But we'll put them on the monitor. If I already intubated them, I get capnography and you can actually see that. And I'll say, okay, see that? I want you to be at 10 or I want you to be at 12. You're going to do 12 per minute. It's super easy to go too fast. Too fast, not good. Too slow, not good. Got to be in your happy medium, right? 10, 12 times per minute for adults, pretty reasonable, right? For children, anywhere from 12 to 20. For neonates, super small little ones, 40 to 60. Right? So again, it depends on where you're at, what you're doing. Cardiac arrest, obviously 30 and 2 for that type of stuff. I'm not talking about that, but I'm talking about ventilations themselves. We may need to to figure out what we're doing. Inadequate, we kind of talked about already, right? We talked about breaths, talked about all these things here. Gastric inflation, gastric distension, inflation, any of those types of things, okay? Some things to kind of think about, advantages, disadvantages. Smaller hands, you know, sometimes can be difficult. The best process, right? The best piece of giving BVM, the best practice is to have a two-hand method where you're going to have two hands holding that mask down. And in all reality, we got two people on a call. So do we have one managing the airway, one doing CPR, one doing thumping and pumping, right? So if that's the case, you know, it's going to be a little bit more difficult to have two people on that. But if in this is best case scenario, right? Where we got tons of people, we're managing the airway, we got one person holding the mask down, we got one person ventilating the patient. Best practice in the sense that, you know, realistically going to get a really good seal. Sometimes somebody without dentures in, super hard to get a good seal because their facial, you'll see it as you get out there, but and think about if you've ever had a grandparent or somebody older that you've been friends with or you've done it with over time, they don't have their teeth in. Well, think about trying to manage that airway, trying to give them breaths with no teeth in. It can definitely, sometimes you wish that they had their dentures in because it's structurally, and if I know they have dentures, I'm going to leave them in as long as it's not going to be an airway obstruction, right? As long as they're secured where they are, I'm going to leave them because as soon as you take them out, the facial features drastically change. Okay, I'm sorry, I'm digressing.
So there was a question like that, and the answer to it was actually you take the dentures out to avoid to remove the choking hazard.
Right. I mean, if there's any risk that they're flopping around, yeah, you got to take them out to reduce that, right? But if they're so secure that I don't really know that they have dentures, or if they're definitely not moving, I'm probably going to just leave them in. But if there's any chance of them becoming a choking hazard, absolutely.
But in our EMT, are we answering it like as if they are choking, or are we answering it as if like if it's secure, then we're not going to remove it?
Mm-hmm.
Okay. All right. Thank you.
You got to dive down to what the question is, right? But I wouldn't get too caught up on that, right? They're going to say, you know, they're going to give you some indication that it's not stable, that it doesn't have whatever. You should see some other indication on that one. Good question though. Let me just see where we're at. So CPAP. Okay, before we go there, let's take a couple of minutes. Offload, onload. Let's be back at 11 because I am running a smidge behind, but that's okay because you guys aren't coming in, so we're going to run a little bit late today because you're going to have a little bit of time. But let's take 9 minutes. Be back at 11, please. 11. Be back, ready to go. As we kind of go through, but CPAP. Share this so you have something to look at. I'll look at my ugly mug. So CPAP stands for basically continuous positive pressure, positive airway pressure, CPAP, right? It is, I'm a huge fan in some respects. In other respects, it's drastically decreased the amount of tubes that we do, but it's really what's best for the patient. It provides ventilatory support to patients who are awake and breathing simultaneously. It decreases the patient's work of breathing, basically. It's definitely, like I said, it's been a game changer in EMS, has really made a huge difference. We need to remember that they have to be breathing, right? Somebody's not breathing, CPAP's not the device we use for them. We break out our BVM and we use that. They have to be breathing. They have to be able to take and accept that. So really important to remember that. I don't want to show up and you have them CPAPing them and they're not breathing, which means you got to take and pay attention and see what's going on with your patient. Sometimes when you put CPAP on a patient, they're breathing at first and sometimes they stop breathing. If they stop breathing, you take that off and you go into your mode of not breathing, right? It's really important. CPAP is useless if they aren't breathing. Not sure how that video will play. Let's give it a shot. Keep our fingers crossed.
Hi everyone. In this video, we're going to talk about how CPAP really works in the CHF patient. What's really going on, because there's some misconceptions out there. Now, to help illustrate this, I'm going to use this BAS right here. And first, we have to talk about how people breathe. Now, let's identify some of the parts of the syringe as they apply to our anatomy for this illustration. So the hole up here at the top of the syringe is the hole in the middle of your face. That's your airway. This would be your lungs right here, and the plunger portion would be your diaphragm. Now, when people breathe, take air in and out of the body, it's mostly through contracture of the diaphragm. So the diaphragm drops down, and like a vacuum, you suck air in under negative pressure. We breathe in under negative pressure. Now let's think about this for a moment. When that plunger falls down, which way do the sides of the syringe up here want to go? Up in the chest. Which way do they want to move? They want to move inward, right? Pull the syringe down tight. This wants to move inward. That's exactly what happens in the human body. And when that happens, it compresses the low pressure vena cava. So every time you inhale, you're compressing that vena cava and you're helping supply some preload, some blood return to the heart. That's exactly what happens. In fact, we call that the respiratory pump. So every time the diaphragm drops down, it squeezes in a little bit, compresses the vena cava, and helps to return blood to the heart. So now, let's say, for example, instead of the diaphragm working, we just blasted air into the top of this hole and pushed the diaphragm down. Which way would the sides go then? Well, they would go outward. They're not compressing on the vena cava. So blasting air into somebody, sides want to go out, we're not compressing the vena cava. So we lose that amount of preload. We've lost our respiratory pump. But when would we ever just blast air into somebody ridiculous like that? Doesn't make any sense. That would never happen. What? Positive pressure ventilation reduces the respiratory pump? Reduces preload and drops your blood pressure? Yeah, exactly what happens every time you're bagging somebody. Geez, I wish there was a way we could help return some of that negative pressure and utilize the respiratory pump. This is the rescue pod. That's exactly what this device does. It helps to return some of that negative pressure so we can utilize the respiratory pump. Helps to compress the vena cava, helps to improve preload. Okay, so let's think about another scenario. Let's say that when the diaphragm drops down and creates that negative pressure, at the same time, we put air into the patient under positive pressure to negate that, to equal that pressure so that the sides aren't coming in, it's not compressing the vena cava, and we're reducing preload to the heart. That's what CPAP does. That's exactly the mechanism we're looking for in CPAP, to negate that negative pressure, take the pressure off the vena cava, wipe out the respiratory pump, and reduce preload to the heart during CHF so the heart can catch up a little bit. Now, when it comes to compliance with CPAP, it's not usually the inspiratory.
Oops, sorry, that was me.
Phase is bugging the patient. It's the exhalation when they're exhaling. Think about it. CPAP, continuous positive airway pressure. Now let's say we put it at 10 centimeters of water pressure, right? So when the patient inhales, they're negating that pressure. They get all that pressure coming in, feels great. The problem is they can't exhale against it. So I have a tip in the field for patient compliance, if your patient is able to do this. Because what's more beneficial, the inspiratory phase or when they're exhaling? The inspiratory phase, we're trying to wipe out that pump, right? Here's what you do. If the patient's able, give them the mask, give them control of the mask. Have them hold the mask on the face and you get a good seal during the inspiratory phase. But if they're having trouble exhaling around that pressure, have them crack the mask a little bit so they're allowed to exhale. That's what it is. They just can't exhale. It's very uncomfortable. It's hard to breathe. It gets 10 centimeters of pressure. Try that, and then as they get you, you'll get better compliance. Now, how do you know it's working? The respiratory rate starts to come down, stats improve, end tidal improves if you have end tidal on at the same time, which you should. So the patient gets better. Another technique, and always follow your local protocol, maybe start the CPAP at a lower level, gradually rise it up so we can get compliance, as opposed to strapping this thing on this patient's head and watching them wrestle. You know, I wish there was a way that we could have a lot of pressure on the way in, but less pressure on the way out so the patient can exhale and feel comfortable. We do. That's called BiPAP. And we use that in hospital, bi-level ventilation. So they get more pressure on the way in to wipe that pump, reduce preload to the heart. When the patient exhales, the machine automatically lessens the pressure, so it's easier for the patient to exhale and you get better patient compliance. Okay, so this has been just a quick review of how CPAP really works. My name's Mark. Thanks for watching. I'll see you in the next video.
So was that extremely painful?
No, that wasn't bad.
I mean, it kept pausing, but
I paused it twice. That was my fault.
It was
no, it's like very delayed, like for the video, but the audio was like okay.
Okay. Well, I mean, there's some good points there, right? CPAP that we use pre-hospitally, you do want to be cognizant of blood pressure. If somebody's got a really low blood pressure, it could drop it a little bit. It's very similar to the sleep CPAP machines that people have. It's very similar. What we use is oxygen to generate that CPAP in the back of the ambulance. Whereas sleeping one, you have a machine and typically it's not hooked up to straight oxygen like we do before, but the concept's very similar. BiPAP, which you talked about, we don't do pre-hospitally, but CPAP is just we're blowing a ton of air in, right? And that makes sense. So the goal is that we don't want to. So with positive pressure ventilations, where we're taking a bag valve mask and we're just pushing, it does. That's what he talked about with that pump, that it inhibits that pump a little bit, whereas CPAP itself helps to encourage that piece. I really think of with CPAP and how my brain works, however messed up that is, according to some people. But really, it's the pneumatic splinting of the airways. It helps to splint them open to allow some of the changes to take place, and that's really what we're looking for. They're trying to take and help splint that. Now, if you see somebody in true respiratory distress, especially somebody who's trapping air per se, a lot of times they're doing it themselves, right? They're piercing their lips and they're creating their own PEEP. They're trying to CPAP themselves, right? You go up and they're like going, well, they're kind of trying to do the same thing. They're splinting those airways and doing that piece. So CPAP helps them, right? Somebody who does that is doing that PEEP where that's an active process. It's a lot of work. Somebody who's sick, who does that all the time, they get tired. Right? They're splinting on their own. They get tired. CPAP takes away some of the effort of that. And that's where the big difference kind of comes in. Just to kind of throw that out there, right? It's non-invasive. Oxygen supply is what we're using. And really it stops us from having to intubate these folks. Before CPAP, we would wait till they got to the point where they would go unconscious, and then we would intubate them. And we know that intubation as the last resort is where we use it. But if we can stop intubation, people outcomes, mortality rates decrease, outcomes are so much better. And we know that a patient who has heart failure, and if we end up tubing that patient or putting in an airway into that patient, it's going to be so much worse off, and it's going to take them that much longer to get out of the hospital if they ever do get out of the hospital. So CPAP itself is drastically decreased because it's a great tool, right? Criteria for CPAP. This is important. Burn this in your brain, right? Typically, it depends on certain protocols. If you go to a different state, you may have a different protocol. Respiratory rate, you know, they're breathing fast. It's adult, obviously. 24 times per minute or greater than 24 times. There's a noticeable increased work of breathing. You look at them and they are working hard to breathe, right? SpO2 less than 94%. You got some modeling, pallor, cyanosis. We've talked about that, right? You get some signs of hypoxia. And then abnormal breath sounds or frothy sputum or something going on, right? All these are great indications, criteria for us to throw on that CPAP on them, right? And it continues to, some of the thresholds was really high when we started. When I first started CPAP and long time ago, 2006, 2008, something like that. That's when I was practicing in Maine. That's when we started piloting and going through the process. But exclusions, things to think about, you know, if there's major facial trauma, if there's been surgery to the question? No? Okay. Whoever that is, just a little bit of feedback there. But so if there's been surgery within the past 6 months, pneumothorax, you know, if they get a pneumothorax, it's gonna exacerbate that. You gotta be clear with that. And obviously if they have an open tracheotomy, if they got a hole in their throat, throwing on CPAP, probably not gonna be effective because they're not breathing that way, right? They're breathing through the hole that's in their throat. Significant chest trauma, blunt, penetrating within the past couple of weeks, you know, and in a few years after we get some more research and more data, that may be a little bit different. There are some promising things, off-label use in different situations where sometimes and I'm not saying we do this, right? But sometimes they're actually talking about using it in a flail chest to help splint internally and externally. So in the future, I think we're going to see some uses change. We've seen it change over the past few years and increase what we can use it for, but we're going to continue to see where that changes. Recent GI surgery, bleed, something like that, you got to be very careful because you can have some major airway issues. Obviously, greater than 12 and your blood pressure, you got to be really cognizant of that as well. Mechanism, you know, basically it increases the pressure. It blows open those alveoli when we're looking at that, pushes across everything across that membrane and really helps to force some of that fluid out. We see it with edema, when they're filling up with fluid, it's a great, that plus some other things that we can do in a paramedic level. So for me as a paramedic, some of the things that we can do on that level makes a huge difference. But CPAP itself a lot of times is a huge game changer. And then when you get your ALS back up or you get to the hospital, what we're going to do is we're going to continue that, but we're also going to give some nitrates. We're going to give some other medicines to help them as well, to offload some of that fluid. And again, a lot of times with CPAP initially, when back again many moons ago when we first started, I had to set it and forget it. You know, you could only go with 25 liters per minute, full of tons of air. Some of the newer CPAP now, the new CPAP that we have, we can titrate, right? And that has drastically helped with the compliance of a patient, especially a first-time CPAPer, right? So the first time that this person's ever been put on CPAP, a lot of times I'll start low with a PEEP or with that rush of air in their face. I'll start low and I'll work my way up. The goal is to get to 10 millimeters of mercury. But if you start off at 10, sometimes that's pretty difficult. So what we want to make sure is as we build up and as we move forward, we kind of get that, especially if it's their first time. It's super scary and it's hard to breathe. And again, you know, they give you that analogy of sticking your head out of the car. Not condoning that, but sometimes if you're going to try it, that's what CPAP feels like. Or when you come to class, you may actually throw on the CPAP and feel that as well. It's not impossible, but it's not the most comfortable thing. And if you're if you're short of breath, how difficult that could be as well. All right. And again, if I'm going too fast, somebody can slow me down, but I'm cranking through a couple of things here. Some cautionary.
I have a question.
Sure.
What was it for, like, when he was talking about the respiratory pump and how we don't want pressure on the, I think I spelled it on the Sina vein, vein.
Right. So in the video, he was talking about the respiratory pump, or the vena cava, which is one of the arteries that comes out, or the vein that goes in, right? So basically, it's what we don't want to do is if we just force air in. If I take a BVM and I throw that on your face right now and I start squeezing it, you're going to be fighting me, right? And your lungs are going to fight me even more. So it's going to increase your thoracic pressure, which then will decrease some of the pumps and some of the other things happening, right? So with CPAP, I'm working inherently, you're going to work with me. So if I take CPAP and throw it on you, when you take a breath, that's going to increase the amount of breath you take, but it's when you take that breath, so you're not fighting that as much, so it's not going to decrease the pump as much. Does that make sense?
Yeah, so normally we don't have a respiratory pump. We're not putting pressure on the vena cava. I'm sorry, I can't say it.
The goal is not to do that, but if we take if I take my BVM and I throw it on your face and I'm fighting you, I'm going to create some additional pressure that I don't want to create. CPAP has made it so we're a little bit better. But when I started, when I started paramedic in 2005, we didn't have CPAP in where I worked, right? That state didn't have it yet. So in 2005, I watched many patients get too much fluid, and you try positive pressure when they're sitting there, and it's super hard to do. You throw nitrates in, you do a bunch of stuff, and you just sit there and watch them drown in their own fluid, and then go unconscious, and then you intubate them, and then you do that. CPAP helps to push some of that out, helps to increase that pump, and help gets things flowing without fighting the system itself. So then it allows that to happen, and it happens pretty quickly, and you can fix a lot of problems. So that's kind of, hopefully that makes sense, and I don't confuse you.
Thank you.
Sure. So as we think of, things that we are going to increase some pressures in venous flow. That's why we want to make sure that we do have a good blood pressure, right? This does cause some decreased workload and helps to drop. It sometimes will drop the blood pressure. So we can't. Somebody has super low blood pressure, CPAP may not be indicated because their blood pressure is too low, below 90. That top number below 90. Got to think about what you're doing. So you'll see when you do ride time and when you see paramedics and EMTs, you got to get the blood pressure, right? And that's huge. You throw CPAP on somebody with too low of a pressure, you're not going to have a good time, right? So you got to know your blood pressure. It's critically important to know, so you don't kill people, right? So too low, got to be careful, but it is a game changer, like I said. Okay. AIM CPAP, what are we trying to do? We're really trying to figure out some of that gas exchange to lungs. We're trying to really help the alveoli from collapsing, which then really causes some issues and problems. Okay. Helps to improve and create a larger surface area where we can actually get that gas exchange. Things are clamped down, whether or not they're really tight or whether or not you got fluid in there. So it helps to open and splint that airway so then we can get good gas exchange, which then can hopefully change that hypoxia. But again, it's something that happens pretty quickly, and it's pretty cool to watch. The first time you ever see it truly work on a patient, you're going to be like, oh, wow, that was so cool. Because you'll put it on, you'll transport the patient within the first few minutes. They're going to start doing it once they get in the groove, and they're going to be so much better. You get them to the hospital, and they're like, oh, this person's not that sick. They got CPAP on, but that's not a big deal. Yeah, because you fixed the problem, right? So things to kind of think about as you kind of progress and move forward. It really, it helps do the work for them. They have to be breathing, okay? If they're not breathing, don't do CPAP. But what it does is it helps them. And initially, you know, people call too late. People call after they've been doing this for a long period of time, and they're just super tired. You know, they typically, it's not supposed to be work to exhale. We talked about that. Inhalation is where the work is. Well, they're sick and they got a different process going, so they have to work to get the air out. So not only are they working to get the air in, but they're working to get the air out. So part of those problems is that they're working really hard. And they're working and they're working, and it's not just for 10 minutes. They, you know, sometimes we get called and we go out and they've been struggling to breathe for days. So if they're struggling to breathe for days and that type of stuff, you want to take and really, am I not showing my screen?
No, I logged out. I wanted to make sure.
Oh yeah, you're good.
Okay.
I would have yelled. Okay. I saw you come in. Tommy's checking in on me, make sure I don't screw up his class.
I was
So really just really start thinking about what we're doing and how we're doing it and what we're doing to make some of these things happen is really important as we go through the process. You know, what we're trying to do is we're trying to get it up 10, 12 millimeters of mercury. We're trying to increase that pressure. All right, we're trying to reduce the work of breathing for that patient. We're trying to get some increased residual functional flow. We're trying to increase the alveolar surface. And again, not all states EMTs can do CPAP. You can do CPAP here if your medical director allows it. And here at Cataldo, we can actually do that. So it is quite a pretty cool thing, right? And it's newer to Cataldo, so things are, you know, changing that we've trained everyone, but this is a huge game changer when you have these patients who are pretty sick. Acute pulmonary edema, if you think about it, it changes the pressure gradients, it helps with the sympathetic discharge, it decreases that preload, kind of mentioned that earlier, but really with somebody with pulmonary edema who's filling up with fluid, and you got all that stuff, really, you can see a difference in 90 seconds. These are the folks you really see in about 90 seconds. You're going to see a huge difference. Again, game changer. Makes a huge difference when you're doing that. Okay. Some other things to think about, you know, sometimes people have holes in different places. Sometimes they have a stoma. Sometimes they have a hole in their neck that you need to do that, right? Can you BVM that? Sure, you can. But you're not going to put a BVM over their face because probably there's some reason that they have a trach, right? If they have a tracheostomy, it's typically for a reason that there's either some blockage up north or there's something else going on. So this is where, if you had to ventilate these patients, this is where you're going to do that. They still can be ventilated sometimes through the mask and nose, sometimes not. It depends kind of what's going on and that type of stuff. Thinking about infants and children, I've already yabbered about this, but look at this kid's head alignment. That's important as you look at the process. And it's important as you look at how are we going to take and manage his airway. This one here on this side, right? Oh, let me get my little highlighter in this. I do love to draw because it keeps me entertained. But look at this kid right here, right? Look at his alignment. So much better airway. I can ventilate him so much more effectively to get the air down. I really got to work on my drawing skills. This, what are you going to do? You're going to be fighting yourself, right? He's in a poor position. It's not going to bode well for you or for him to really effectively ventilate this patient if you had to do that. Huge, right? When we're thinking about patients in trauma, right, in facial injuries, you get this horrible picture of this kid again. Sorry, I didn't make this up, but you know, or some other facial trauma, you're going to have to think about how are we going to adequately ventilate this patient. It's going to suck. It's not going to bode well, right? Do we need to use an OPA? Can we use an OPA because this guy's so crushed, or what else is going on with them? Are they going to have a swollen airway? If they got a swollen airway, do I want to make it worse by shoving something in there? You got to be very careful of that. Dental appliances, we already talked about, but if they're secure, leave them in place, right? If they're loose and they're going to be a problem, yeah, you're going to have to do that. You got to reassess the airway and make sure you do that piece too. Oxygen therapy, when we're thinking about oxygen themselves, realize that there's different sizes. We got M tanks, we got H tanks, D tanks, all these different types of tanks and that type of stuff, depending on how much and how long, right? We're giving CPAP, that sucks up a lot of oxygen. You're going to burn through a smaller tank in a short period of time if you got it flowing at 25 liters per minute. Now, the best part about a lot of the CPAP devices we have now is that they run on less oxygen, but you still got to be cognizant. You only got a half tank, or you got a tank that you probably should have changed out that you didn't because you're lazy. May not bode well if you get that respiratory distress patient. You got to hook up CPAP, and now you don't have enough oxygen to get you outside the building. So think about what you're doing, how you're doing it. Typically, they're pressurized at 2,000 PSI, whether or not it's a huge tank, whether or not it's a small tank. They're going to have the same PSI. It's just going to matter on how long you can be at a high flow leader. Typically, a D cylinder, we carry those a lot. That would be the D cylinder here. D cylinders are 350 liters. E cylinders a little bit more, 625. M or 3000 H, which is a really huge one, that's 69. So our trucks have oxygen in them. Those are the big tanks. Those last for quite some time. But there again, you can run it out. Duration of flow. Again, if you think about a D tank that has 1,000 PSI, it probably has about 175 liters. So if you think about that comparatively, like an M tank, which are the big ones we have in the ambulance, that has 1,000 PSI, that has probably about 1,500. So again, comparatively, looking at the size, understanding a higher flow rate, the faster the oxygen is going to be depleted. We use so much less oxygen now than we used to when I first started, because we're truly using it when we need it as it's indicated versus throwing it on every single patient. But you want to make sure that don't be a lazy provider and, oh, well, it's 600, we're set. Well, are you set? Because if you got to transport somebody out, if you got to take somebody out of the house and they're on CPAP in the 3rd story, it ain't gonna last for you, right? You're gonna run out of oxygen and your CPAP's gonna die, and then all of a sudden that wonderful treatment that you're doing now is useless, and now they start filling up again and they get even sicker. So just realize what you're doing, how you're doing it, that type of stuff. Safety precautions, make sure that you understand what's going on, that you're not throwing them around. They are pressurized. Oxygen regulators, you guys will go over that in class quite a bit. There's different types of oxygen regulators. There's some specific ports, like this one here. You can see the port here. That's a special device. Sometimes we'll run various things off of that. We'll need a certain amount of pressure. This here is that piece that's going to go to your patient. And again, you'll go over this at nauseum with hands-on, so I'm not going to spend a ton of time with that. Oxygen humidifier is another piece. Oops, let me clear off that, but another piece that you may or may not see depending on where you work and what you do. But basically, it gives us the ability to humidify the oxygen. We'll see this with patients, long-term oxygen on oxygen all the time, long-term intubation. They may have some humidified oxygen. Pre-hospitally, not something we really mess around with a ton. We really take and just focus on that. Okay. Will CPAP be on our written exam? National Registry, you could have a question theoretically. It is within the National Registry scope of practice. So it is a possibility that you may have to deal with that. Hold on just a second. Got somebody that really wants to talk to me. Okay, so so yeah, there is a possibility that you may have something on that exam. It's within the national scope of practice. Indications for oxygen use. You know, when are we going to slap oxygen on a patient? How do we know when to put oxygen on a patient? What's your thoughts? I mean, what do you think?
When a patient isn't breathing correctly.
Possibly, right? Possibly. when they got low pulse oximetry is one of the guidelines, right? The pulse oximetry now more than ever is really to be somewhat of a baseline. If they have some signs of hypoxia or risk of being hypoxic, sure. Somebody tells me they're short of breath and they need oxygen, I'm probably not going to deny them, right? But I'm not going to just throw a high flow non-rebreather on them. I'm probably going to put a nasal cannula and give them a little oxygen, and if they feel better with it, great. And if they don't, then maybe I'll titrate it up. Well, SpO2 now is really standard of practice in the sense that, you know, anything below 95% pulse oximetry, you know, pretty good indication that we're going to do that. You know, anybody in cardiac arrest and that type of stuff, we're going to put high flow O2, we're going to do all those pieces, right? We're going to do everything we can. But somebody sitting up talking to me, I may not throw a high flow O2 on them. I don't necessarily have to do that at this point. And again, when I first started, you know, somebody in having an MI as a paramedic, even when I first started, throw a non-rebreather on them. Well, we do know that oxygen is a medication and it is not a benign medication. So if we give it to everyone, we could do more harm than good on some people. So if they need it, absolutely. If they're requesting it, if they have to, if it's what they need, sure, you could do that. But just be cognizant of what you're doing. It's no more set it, forget it, throw on a high rebreather. Now, that's reality. That's best practice. That's where we are in Massachusetts and other states and all that stuff. National registry, you're going to put on a whole lot of high flow O2 because that's how the test and practical exam is written. I'm not negating that at all because that's what we have to work with. But in reality, when you're on the truck with me, I may not put them on oxygen. I may put them on oxygen. It depends on what they need. Okay. Some hazards, some things that we want to think about. Obviously, you have a very tank that's under a lot of pressure, so that could always be a problem. We also have different mechanisms and other things like that. And oxygen itself as a medication is not benign, and you can have increased free radicals, and you can actually cause some other issues. If you're doing this, make sure you check the tank, make sure you check the flow meter, make sure you see what else in that you've assembled it properly. The best part about O2 regulator, if you screwed it up, you're probably going to hear that you screwed it up pretty quickly. But make sure that when you're applying it, you know what you're doing, you're double checking, making sure that you do that. If you do have to reassess and fix something or change that, take the mask off the patient and fix the problem. Don't necessarily do that with it on the patient. That could be problematic for you as well. Non-rebreather mask, really what more so, like we'll call a lot of things a non-rebreather mask, but in essence, non-rebreather mask typically has a little seal on the side and you actually can't rebreathe. A lot of the masks out there are just simple face masks. So it'll look like a non-rebreather, but it'll actually have a hole in the side. That's technically not a non-rebreather, that's a simple face mask. Very similar, but as far as oxygen delivery or something, you could rebreathe some of that, so it's not 100% oxygen solely on that, like it is with a non-rebreather. So just things to kind of keep in mind as you go through, right? Come on, there we go. Nasal cannula. Remember that we're putting it in anatomically correct. Usually most of the nasal cannulas have a little curve, so you want the little curve to go right in the nose. Don't have it going backwards. If you take 2 seconds and look at it, you should be able to figure that out. How much oxygen are we actually delivering with that? We're delivering 24 or 44% typically with that, and that's what we're delivering, right? Other types of devices, we could have a simple face mask. I've already talked about that, or Venturi mask, or other types of portable masks that we'll see from time to time. Questions? All right, let me stop this for a second.
Yes, I have a question. Which mask do we use on a trauma patient?
So, good question. For a trauma patient, if you're doing high flow O2, and for state practical exam, you high flow O2 on a non-rebreather mask is well appropriate, right? To be honest with you, I don't always give trauma patients oxygen. If they need it, I'll give it to them. If they don't need it, I'm not going to necessarily do that in practice. Now, that being said, for for the National Registry exam, you're going to be doing a whole lot of that. So for trauma patients, if they truly need oxygen, I'm going to do it. I'll put a mask on them, or I'll put a nasal cannula on them. That's where I'm going to determine what they need. So I may put capnography on them so I can look at waveforms, so I can see how they're breathing, so I can do different things. All depends. So not a simple answer, I understand. But you know, the mask is a non-rebreather, and that's for National Registry purposes, you're going to do that. But in practice now, we do that much less. We just wanted to show you. Since we're on this topic, where is it? So here's a gentleman that I had an interesting call with. A little bit different, but this shows you a good piece of what we talked about, retractions. This will give you an idea. Now this is different because he actually has a little bit more depth, which you'll hear in just a second. But let me try this. I did this in class the other night. It worked out pretty well when I did a slow piece of it. So let's see here. You should be seeing it now. You guys see that? Yes.
Yeah, we see it.
Perfect. All right. Evan, did you have a question?
No, I was just saying that we can see it.
Okay, excellent. Thank you very much. All right, so here.
Here's pushing in against my hat. So your sternum was pushing against your heart? Yeah. And they removed your sternum? Yeah. Is that when you had your heart attack 6 years ago they did that? Yeah. Yeah, okay. And you served in the military? Did you get injured at all in the military or no? Yeah. What did you have done there? A whole bunch. Yeah. A whole bunch of stuff, yeah. So your sternum's been removed? Yeah. Just a piece of it? Whole thing. The whole thing? The whole thing. Did they put a plate in there? No. How about somebody? For how about somebody? Yeah. Is it sore or sensitive at all? Yeah, I bet it is. How about him? Do you have pain in the stomach usually? Yeah, once in a while.
So could you guys see that a little bit? Might have been a little choppy, but did it come through somewhat?
Yeah, we got it.
All right. Kind of a dorky guy talking, just ignore that one. But when it's a different type of case, but that when I talk about retractions, you saw where his chest kind of caved in. Well, retractions, when somebody's really struggling to breathe, look like that. You'll see ribs and everything get kind of sucked in, and that's looking at that. Now, also some things to point out, right, with this gentleman here is that he's not, you can tell when he's talking, he's still got some type of shortness of breath still going on, right? He's not just sitting there blabbing, blah, 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 going off, right? You can still tell he's peeping each time he's breathing. He's still not normal respiratory as you're looking at that. So you want to be assessing what's going on with your patient, what's happening, that type of stuff, and really trying to figure out what's going on. What do you need to fix? What don't you need to fix? All those different types of things as you're kind of going on your way to the hospital, as you're going through and treating your patients as well, right? Things to kind of think about as you kind of go through. Let's see, there's another one.
Did he really not have a sternum?
He didn't. He had his sternum removed. Kind of cool. A little bit different, right? And that's why that one got videoed. All the Real DX is pretty cool. We get to work with them from time to time. I've created some content for them, but it allows us to really see some real cases and that type of stuff. So another one I'm looking for, and obviously some of these are real life people, so sometimes it's hard. One second here. I had everything set and now it disappeared. So where are I now? Here's another good one here. Here. Just take a look and then we'll talk about it, right? Obviously, I'll talk because I have that ability.
Okay, we're here with a 3-year-old male who presented with some respiratory distress. We're going up to Dornbecker currently. Mom, can you tell us what started this?
Last night he started coughing and complaining of not feeling well, and this morning I noticed he was very lethargic. He had a lot of breathing troubles.
Okay. And did you give any medications at home?
Yes, I did an inhalation treatment and used his inhaler as well.
Okay, so he has a history of asthma, and he got a duonev at the facility, the immediate care facility where we picked him up. We've done one duonev treatment at this time, but we still have some paradoxical breathing. He's working pretty hard here, and if you look closely, we can see a little bit of nasal flaring. But other than that, he's been very brave. And we'll see where it goes. Any other medical history?
No, just a lot of breathing troubles.
Okay, and normally it's exacerbated with exercise, correct? Okay. All right, thank you.
So again, as you're doing your assessments, as you're evaluating our patients, you kind of want to go through. If you're looking at this a 3-year-old, the heart rate's 130. Is that bad for him? I don't know. Respiratory rate 50, right? Kind of looking at this patient. He's 3 years old, right? Is this something that you would expect this patient to be acting this somnolent, this quiet, a 3-year-old?
No, absolutely not. I got a 3-year-old. I got a 3-year-old. Nope.
Somebody speaking from experience, right? But
Yeah.
that's not a normal kid in the back of an ambulance, right? So he's still pretty sick.
You could tell by his eyes, he was pale. He looked sort of like in shock, but he couldn't, his body's working so much harder to breathe. That's why he's sitting still.
Yep. Good. So again, all these things that you really want to look at, and this was a regular transfer of the units, right? So you can learn a lot from transfers and really get to work with patients and to go through. He's had he had some treatments, that type of stuff. Let's see, diagnosis, what they come up with for diagnosis was respiratory distress, asthma exacerbation. But again, this was a kid that was a little bit tougher, right? Let me see if I can find the other case I want to show.
Can I share something with the class?
Sure.
So I was saying, I'm surprised you don't have my son in there. I have a son with trisomy 21. And he's 20 now, but back when he was like very little, several times ambulance were called to my house where he was cyanotic, he was retracting. He was basically, they had to bag him like right there. Bag him, board him, and get him out the house. So yeah, and he had a trach and he had a G tube and he was very complicated. So I don't know, I just wanted to share that.
Sure. Yeah, they can be pretty tough cases, right?
Yes, absolutely.
Where is? So there are some taking this one here, right? This little one. And sometimes with the children, you can kind of see some good indications here. Let me play. And
okay, this is a 10-week-old baby who admitted to the hospital.
Things to look at, right? This baby's admitted in the hospital. Watch the breathing, watch the respiratory as this physician goes through this piece, right? Watch this little one breathing and understand that, you know, they breathe faster, but really some things to kind of look at.
He has inability to eat properly. Initially had low oxygen saturation on fingertip, and with oxygen initially was 62% and will go up into 80% with oxygen. When the baby's out of oxygen, drops back down again. The cardiac exam does not reveal any murmurs. The chest X-ray reveals no real obvious severe cardiac disease. Just have the club foot, as you noted before. The baby is being fed. We're still without a diagnosis. The baby's not severely anemic. We don't have an echocardiogram done. We don't have a repeat chest X-ray. And there's no murmurs on exam. You can feel.
You can see with the respiration here. Look at the breathing here.
Basic issue here is this some kind of a primary lung disease, or is there some?
So some of the challenges, right? Not always easy to see or watch and that type of stuff, but there's some of the challenges. But when you're looking at respirations, when you're looking at different things, you really want to look at, you know, how are they breathing? What's going on with them? Different cases like that. Okay. So in when you have adults, as you kind of go through, again, you want to kind of look at how are they breathing? What's going on? Is there any obstruction? What is the obstruction? Is it something that we have to take care of? Is it something internal that we got to use CPAP for? Is it something else? Okay. So just a kind of couple food for thought as you kind of go through, look at some of the different situations and that type of stuff. So we'll hit the pharmacology a little bit more after. You guys have some work you need to get done, right? So make sure that you kind of take care of that. Any questions or burning things for me? I have talked to Tommy. He's well aware that a couple of you had a couple of things. Make sure you just communicate back with him. Get that work done. You are expected to have the FEMA stuff done and the mandatory reporters training done today. You have the time this afternoon to get that done. Any questions before I let you go for the afternoon to get your other work done?
I was looking through it, and it says like a estimated time for them. I think it's upwards of like 9.5 hours total. So like, it's okay if like we submit, like we finish real late tonight or something.
Yeah, it won't take you 9.5 hours.
Okay, because one of them said like 4 hours, another one was like 3.5, and then one was like 2 hours.
Yeah, that's pretty conservative timing, to be honest with you.
Oh, okay, thank you.
Yeah, don't. Yeah, you. If you're at midnight, I'd be. That's not good, right? I'm not telling you don't do that, but realistically, you have the appropriate amount of time to get them done this afternoon by the time you'd be done. Good question.
Okay, thank you.
Yeah. Any other questions?
What are we doing with those? We just emailing them to you?
Yeah, just taking the completion certificates, email them to Tommy, and he'll put those in, and that will be your completion piece of it. Make sure you keep a copy for yourself, because to be honest with you, you're going to need them wherever you go.
Do we have to CC you on that email?
No, just Tommy.
All right, sounds good.
All right. Any other questions? All right, good luck, get everything done, and you'll see Tommy on Monday. Take care, everyone.
Thank you.
Bye.